the crew were injured, one seriously. Sadly, one of the crew, Alice Clark, tragically died at the scene. Philip, our Chief Executive, will now pay tribute to Alice, followed by a period of silence so Alice can be in our thoughts. So Philip.
Thank you, Chairman. I will say a few brief words and then I'll ask you to join me in a minute's silence, which we will take at our place. I will call the end of that silence and then we'll return to the meeting. So Alice completed her degree only late last year. She didn't do her training with us. She did it with London Ambulance Service, where she gained so many friends that this tragedy doesn't affect just one family. It also affects our family and also the London Ambulance Service family. She joined CCAN at the end of her degree before Christmas, about a month before Christmas, and she instantly made a deep impression with everybody in her station in Kent at all levels. She was tragically involved in a horrific road traffic accident whilst on duty on the 5th of January. And despite all efforts of colleagues and other emergency services, she couldn't be saved. Alice was only 21 years old, but she was already a shining star to everyone who met her, and she will be very much missed. We will remember her. Thank you very much, everybody. Farewell, Alice, and I'll hand you back to the chairman.
Thank you. Rest in peace, Alice. We send our condolences to your family and all those affected by the tragedy. Right, let's move on to the public board meeting. Just a few house rules, if we may. If colleagues are not a formal part of the meeting, if they could keep their laptops on silence and their pictures off, please, just to preserve bandwidth. We, as always, welcome members of the public and those observing the meeting, and there will be an opportunity at the end of the meeting for questions to be asked about the business that's on the agenda. This is a meeting in public, not a public meeting. So can I move on now to apologies to absence, please, Philip? Please, Peter.
Yeah, just today, David Hammond and Laurie McMahon. Phil Astle, Deputy of Finance, is here in place of David.
Thank you, and welcome, Phil.
Thank you.
Declarations of interest, they are listed on the agenda. The list has been updated. Is there any other declarations of interest that we need to take this morning? Thank you indeed for that, confirming that. The minutes of the last meeting, I think you've got one amendment, Peter?
But one board member, Chairman, spotted a deliberate mistake of the date that would still showed September instead of November, so I've corrected that. Thank you.
You like to keep them on their toes, don't you? Thank you. Moving on, does anyone else confirm they're a true and accurate record?
I'm happy, thank you, Chair.
Happy with the actions that are ascribed to you? Okay, thank you. The action log, please, Peter.
Yeah, again, just 2 actions as stated in the log itself, Chairman, both for Workforce and Wellbeing Committee, and one's on the agenda for the next meeting coming up in a couple of weeks' time, and the other will be added to the business plan for the coming year.
Thank you. Moving on, just to use my chair's report just to sort of detail the business of the meeting. I'm afraid it's a rather longer meeting than normal. We don't normally have the part 1 meeting split over lunch, but I think it's important. We've got some really important business to transact today, and it coincides with that time of year when we need to take a number of annual reports. But although the COVID emergency is still with us, there are some signs that things may be turning, but as I don't wish to be too optimistic. However, it's important that the board keeps a sense of progress and on items that involve the trust, and the last 2 years particularly have been quite appropriately dominated by COVID and our response to the COVID emergency. But nevertheless, it's our duty as the board to look to the future and make sure the organisation has good policies and procedures and strategies in place to manage that future as best we can. And it's clear that as we emerge from the pandemic, both the NHS but also the wider public services in the country will face a number of challenges, not least of inflation from the financial challenges of the country, but also of changing way of work, of the way the world has been changed completely by COVID, and ways we expected things to develop and not quite always panned out the way we expect. So we need to make sure we can manage uncertainty and manage that future as best we can. So on the agenda today are a number of items which are future focused, and it's important the board unite behind them, particularly the Better by Design programme, where CCAM is seeking to transform its operation to look to the future and realise we do need to change the way we work in order to give the best service to our patients, but also to work in partnership with our other colleagues in a more integrated National Health Service and social care system, but also give our staff a great place to work. So it's really important. It's still early days in the development of that programme, but it's fundamental to the work of this board, and it will be an important part of our agenda over the over at least the coming year and longer. We've also got our normal board committee reports, but I think it's important that some of that captures the midwinter period we've been through, where we expected to see really challenging times for the NHS and for the ambulance service, and we were not left disappointed in that sense. Our predictions came true, and thanks to some very good work we've done in anticipating workload, we were actually able to manage that process relatively smoothly, not least though because of the excellent commitment of our staff in managing some very, very difficult situations. But the board committee report picks up that work that we've done, and the work that we've commended our staff for keeping quality in focus in a time when it would be so easy to be completely dominated by COVID and the next response. We have attempted to ensure our patients do receive a quality service, and we monitor that closely through our board committee work. And some of the papers today, again, signal our approach to patient safety in the future, which I think is important, and again builds on some of the excellent work that has been undertaken in the trust over the last couple of years. So we are moving forward. There's a different health service in terms of structure coming into place in early April. The legislation has still not been passed for that in Parliament, but those organisations will be working in shadow form as if they were in place. So we are into a new structure, a new service, and it's important that we're prepared for that. So that sets the scene of what's to say is a long meeting. We have factored in some breaks to make sure the board members retain attentive and their physical health is maintained at that time, and we'll call those breaks when the business allows, and they're indicated on the agenda. So can we move on, please, to the BAF, the Board Assurance Framework, Peter?
Thank you, Chairman. So this is the BAF risk report. It's the usual format the board is now familiar with. In many ways, as I often say, section 3 is the most important part of the report. As this illustrates the extent to which there is oversight of these BAF risks through the board, either directly at these meetings or via one of its established committees. I think, as demonstrated in the report, there continues to be the right focus on the BAF risks. The report, therefore, is aimed at providing assurance to the board that the principal risks are firstly identified and then that they're being, proactively managed. In this version, board members will see that a risk be removed related to system engagement. That isn't to say that it's no longer a risk, but the executive feels it's not a BAF risk, and instead will be managed in the usual way as part of the risk register. And then two more things just to add, as set out in the report, Chairman, and that's two risks that have been added since the last version. One in relation to the compulsory COVID vaccinations, which follows the legislation passed earlier this month, and there's a separate agenda item coming later. So I won't talk about that specifically. And then in relation to the 111 single virtual contact centre, which I think I'll hand over to Emma, Chairman, if that's okay, if you can just give an update on this emerging risk.
Thank you. Emma, good morning.
Yes, good morning, thank you. So I'm going to pick up two pieces of work, one related to 111 and one related to our 999 Emergency Operations Centre. There is national work being led by NHS England in both of these areas to look at how we can create a more integrated approach to managing 111 activity and 999 activity. The 111 virtual call centre concept is that rather than having individual providers, we group together and manage call flows on a regional basis, but actually more on a national basis as well. This is mainly through IT changes, looking at how we can create synchronicity between telephony as well as our CAD systems. Obviously, it's a very significant challenge. It does have some clinical risks, and the national clinical team are working with all of our regional clinical leads to consider and be able to really quantify those risks. There was an expectation that the phase 2 of the implementation of this, in terms of not just the call handling, but the clinical queues themselves, would go live by the end of this financial year, but that at the moment is still under discussion, both with NHSE and our commissioning colleagues, because obviously 111 is a separately commissioned service involving a multitude of providers regionally as well as nationally, and we all sit on different contracts that work in slightly different ways, really recognising that those contracts have been built through the long-term plans that NHSE have published around integration across systems. So a lot more to be done on that, but we are having very good conversations with NHSE and our colleagues across the southeast, because we're being asked for a regional development plan. So more to come from that. I think it's just to add that we will be building on established processes. So 111 has a national contingency offer at the moment. So if a provider has an outage, for example, or a situation where they cannot answer calls, they are able to flow those calls across to other providers. This new process has an intention that becomes a bit more of an automated algorithm-based system. The intention within the 999 control room is to have a similar integrated platform. Again, we have a process at the moment where we have buddy sites. Each ambulance service has 2 buddy sites, so that if there are overflows or if they need support, we can reach out to our buddy sites. But again, the question has been here: can we create a more integrated algorithm-based way that allows these calls to flow through the system to manage any individual surges in a smoother way? Again, recognising we're all on different CADs, we also use different systems. There's going to need to be quite a lot of work around the IT of that. But all of the ambulance services and our heads of operations and IT leads are working together on that. So I think that's probably, Chair, my update on both of those pieces to the committee today, recognising there's still quite a lot more work to do.
Thank you, and I think that's important, obviously, for the board assurance framework. Can I ask, given the importance of the subject and particularly the need to explain both to make sure there's risk is managed, but also there will be ultimately an explanation to the public about that, to reassure the public that this system this potential is going to be safe. Can I ask the appropriate board subcommittees, again through the performance committee in particular, we pick up the implications of that, and I think it will need a full paper to the board when appropriate, in order that we can give the matter appropriate scrutiny. Colleagues, you've heard from Pete about the assurance framework and some additions from Emma. Are there any questions from board colleagues regarding the assurance framework? Michael? You're on mute, Michael.
Sorry, I apologise. Emma, thank you. Very clear update. One question I asked, not necessarily relating to CCAM, you make reference to the digital IT platform. what really irritates the public and the people that we serve is when these IT systems don't work and they're left in limbo. You know, to be quite frank, I've heard many times wonderful statements from the NHS and the Department for Health about what they're going to do on the digital platform. How confident are we? Well, it's a bit unfair to put this question on you, but it's something around we are doing everything that we can from a digital perspective that is within our control to make sure that this integration is going to work. Because what I don't really want is, you know, 3 or 4 years down track when there's a Committee of Public Accounts report that CCAM was a weak player in this. You know, I think I know the answer. I know you're doing your best, but I'd like assurance that, you know, that we are really addressing that integration risk and minimising anything that could arise from our own digital contribution.
Thank you, Michael. Emma, do you want to comment?
Yes, thank you, Chair. I absolutely support your question, Michael. I think there's been a lot of investment, not just for us, but all our partners who deliver 111 and other urgent care services across the region in IT platforms to support it. Our Kent and Sussex commissioners and partners are very happy with the 111 service that we are providing because of the integrated CAS and how it flows into the system to help manage demand. That's what these IT systems have been set up for. I think my understanding from the NHS EIT team is they're looking at how they can create a cloud integration mechanism so that our individual ITs will continue working. I don't believe this is moving us or trying to move us all onto one system. This is about trying to create better flows. I think it is a real challenge because we also, one of the big risks that not only us as an ambulance service, but a number of other ambulance services that deliver 999 and 111 have raised is that one of the key commissioning intentions of our services has been to create integration. So and that's within our own services. So in the last, 12 months or so, as we moved the platforms together, we now have dual trained our staff. So they are able to both answer 111 and 999 calls. We have a single CAD system now. So those two things together have really brought some better efficiencies and effectiveness for the delivery of our service. So the challenge has been back is we're not prepared to consider unbuckling some of this in order to try and create two different separate services, and our commissioners are fully in support of that. So there's a lot to do. I think the other thing that's interesting is it isn't just us. There are other systems where they have embedded a single IT system across all of their urgent care, and again, it's understanding the implications. So my understanding is the offer that it's being made is about how you create a cloud-based mechanism for integration that won't destabilize individual platforms and individual service delivery functions.
Okay, thank you. I welcome that assurance. Thank you very much.
Thank you. Philip? You're on mute, Philip.
Emma's said most of it, Chair. But Michael, I take a little bit of extra assurance is that the mechanisms that we will be using to pass patients from one trust to another appear to be the plan is that that will be the same mechanism that we're currently using, and so we know it works.
Okay, thank you.
Thank you. But I think just in summary of that, it's an important item. I think we do need appropriate scrutiny via the Performance Committee, but also emerging interest from the Quality Committee as well, because all I hear from what I'm hearing here is potential for risk, and we carry the statutory responsibility for the safety of our patients. So I think the board expectation is, Emma, the maximum visibility of this item. We appreciate the way you've articulated it. We will take through the appropriate board subcommittee, and we look forward to. I certainly look forward to briefings with Philip and others. So when in our national discussions, we can speak with the united voice from CCAM, as well as being supportive to the wider National Health Service. So can I move on from that item? I see your hand is still raised, Michael. Is that by?
No, I'm sorry. I apologise. Yeah. Thank you.
Chair, Paul Broadhurst's hand up.
Sorry, Paul. Yeah, do come in, Paul.
Yeah. No. So the devil's in the detail here, because like Philip and Emma said, that we've got quite a lot of things in place, but it's really understanding precisely what they're trying to do and making sure we look at the implementation and how the thing's tested. And we're not at that stage yet. So we have got quite a lot more work to do, but we need a lot more detail on precisely what's going to be done.
Yeah, it's early days, but it's important. We need to keep track of this. Okay, thank you. Can I, other than that, I'm take the board are content with the board assurance framework, and we have identified the principal risks. Thank you. Move on now to the Chief Executive's report. Philip, if you'd like to pick up the highlights from your report.
Thank you, Chair. In my normal fashion, I will assume that everyone's read the report, the written report, and I will either update it to cover the time that since it was written, or add to it rather than go through it specifically. First, I'll talk about the pandemic, because when we last met in public, we were just looking at the beginnings of Omicron, and since then we have done a vast amount of work to plan for the Omicron spike, and we've indeed been through that Omicron spike, and for ambulance services, the spike started tailing away about 2 or 3 weeks ago, and the hospitals are probably 2 weeks behind that. So it's still affecting everybody, but not in the way that it was a little while ago. But there is no sign of the disease going away. That's a message we need to be very clear with our people, with everybody else that's listening, because you can see as soon as the kids go back to school, you can see the case numbers rising again, even though the Omicron spike has passed. In our the major effect on us of the Omicron spike was actually staff sickness, and I think Ali will be talking about staff sickness, and Emma will be later, so I won't go through it in any details. But at its worst, we got up to about 400 staff off for COVID-related reasons. That's in this spike. That's slightly better than when the Alpha variant came in last January, where it got a bit higher than that. But what is we are having to keep a very close eye on is the number of our people with long COVID is continuing to increase, and that had stabilised for quite a long time, but recently it's just creeping up again, and we're now over 40. Now 40 doesn't sound a lot, but that's 40 staff who potentially haven't been working since last January. So nearly 2 years, sorry, January before, the earliest ones. So we are keeping our eye on that. It's plateauing at the moment at about 270, somewhere around that, and we'll keep our eye on that. Other sickness also remains higher than we are used to, and that we plan for. And that's significantly because of additional staff suffering stress and anxiety disorder, particularly higher numbers in our call centre environments, where things have been incredibly busy for a long time, and that pressure is showing in that way. The hospitals and the systems that we operate in are also under significant pressure. Now, we've been in our highest level of preparedness, which we call REAP 4, and the hospitals have a different mechanism, as do the systems. They go by OPAL, but and OPAL 4 is their highest, and all of our systems have been in OPAL 4 on and off for the last 6 to 8 weeks. And they continue to go in and out of OPAL 4 as things go. The biggest issue for them is getting well patients out of the hospitals, and that's significantly connected to shortages and closures in the social care world. despite what I've just been talking about, our performance is now better. And so we made the decision as an executive yesterday that we would lift the business continuity incident that we declared last July, and we would move from our preparedness level 4 down to preparedness level 3. It reflects our performance relative to other ambulance services, some of whom are also de-escalating in a similar way. We'll keep our eye on that because there are headwinds that we still have to face, and so we will watch it, and we will only change those levels according to what actually is happening to us as a business. One of those headwinds, which we'll cover later, is the effect that we may get from the compulsory vaccine legislation, and Ali will talk a bit more about that later in the meeting. But that's the sort of thing that could cause us to change back up to a higher level if it's significant. But we don't believe that it will be that significant. But I'll let Ali talk about that more. We continue to make good progress. I'm delighted to say, despite Omicron, on our estate work on both Banstead and Medway, and the other bits of work helping to tidy up and improve the environment for our people. Really important for us. And despite the ops pressure, we've also been pushing forward on our strategic agenda significantly. Work is working still at remarkable pace in our planning, our new planning directorate, and you'll hear later some of the changes that we've been able to make because of that strategic change that we made last year. So I won't say any more about that at the moment. In terms of people, I note in the report that we've said goodbye to Bethan, and we haven't quite said hello to Rob Nichols. He joins us on the 14th of February, and we'll then go into a period of learning before he takes on the full mantle, but he joins on the 14th, as I say. Thank you to Judith, who has stepped up in the meantime, and she's here as a full board member today. Lastly, we also say goodbye to someone who has been a very, very long-standing volunteer, and I just wanted to say to everybody, you'll all know him, we've finally said goodbye to Francis Pole, who has been with us since the trust formed, and was with other trusts, our antecedent trusts before that, and has retired due to ill health and sadly just the passing of the years. But he's been a great servant as the head of our chaplains, and we look forward to working with the remaining chaplains and under the leadership of Paul Furman. Chair, I think I will leave it at that. My escalation to the board, where is about operational performance, and quite rightly so. But that we'll pick that up later during the session on ops. Thank you.
Okay, thank you. So your report is very comprehensive, and you just take out the edited highlights. Many items in your report are on the agenda. But our colleagues, do colleagues have any questions of Philip regarding his report at all?
Howard's hands up. Yeah,
Howard, good morning.
Good morning. Yep. Thanks, Chair. One of the other potential headwinds would be an outbreak of flu. And I note the flu vaccination levels at about 58%. Could you comment on what you're doing on that front to try and up that level?
Yeah, so we've got it's slower than last year, but that's because we tied it to the vaccination program. Sorry, the COVID vaccination program. So we had that meant because we were operating with Pfizer, we only had licenses to operate in a few places. But since we've stopped and we've closed that vaccination centre, we have gone back to having a mobile facility. And that is pushing up the numbers very successfully. Judith, do you want to add anything?
Yeah, we think it was because the national directive was to link to COVID vaccinations, and where we did it, it's certainly lower than I would want it. Herd immunity is 75%, and we are trying to get there. We're in a line with other NHS trusts actually who have struggled as well. I think there's one ambulance trust nationally has achieved a better figure, but we're all struggling. We have taken a decision though. We're delivering it now kind of locally. We're also following up staff that we just haven't heard if they've had it enough or not, because it could be that they've just gone to chemists or GPs, etc., and had it there. But we have taken a decision that although your sort of official flu reporting data finishes kind of early to mid-February, you don't actually have to stop vaccinating then, and you certainly don't have to return say-plus vaccines till about May. And as we see this as a resilience measure, we will keep offering staff as long as they want it. And
finally, Howard, on this question, of course, our IPC stance remains much more coverage. We're not taking, we haven't released everybody from everything as is happening to the general public. So we're still wearing masks, we're still keeping distance, and we will continue to do that. That gives us significant additional protection from flu while we continue to do that.
Thank you. Thank you for the question, Howard. Subo, then Chris.
Thank you, Chair. Thanks for your report, Philip. I'm really good to hear about the lowering of the REAP 4 to REAP 3. I just wanted to ask you a quick question about the staff survey, because you say in your report it's 61%. How does that compare with previous years? And if it is lower, is that a reflection of the situation we've been in?
So thank you, Suba. It's lower than last year by 1%. And last year was our highest, I think our highest ever, certainly our highest in the last decade. So it's an insignificant fall in terms of how many people took part in it, but we wait to hear. And I would expect, and all the chief executives are saying that they are expecting to have far more worries indicated by the staff survey this year than they've had in the past. So I wait with interest, and we're going to have to do some serious work this year on as soon as we get that data.
Thank you. Can I just perhaps bring in Ali here? How do we compare, Ali, with other NHS trusts and other ambulance trusts with our rate?
Yeah, I think it's worth saying. So Philip's right, we are a percentage point or so lower than last year, but they're the two highest response rates CCAM's ever had, actually by a long way. My understanding is that the average response rate across the country is likely to be somewhere short of 50%. So it's likely to be in the high 40s, I think, as a country. And other ambulance trusts are sort of all in that sort of level. I do agree with Philip, though, that actually we're likely to see, I think, some difficult results again, actually just reflecting the really difficult time that people have been in, and there's going to be plenty in there, I think, for us to kind of work on in the coming months and years as well. So, but that's the sort of specific answer to your question, Suba.
Thank you. That's a good point we raised there. And I think we would expect that we want to see accurate returns. We want the information. We want to work in partnership with our staff to improve their work experience and service to patients. So it's going to be vital feedback. And we have come through a particularly difficult 2 years. So in some respects, this information is going to be crucial, isn't it? Thank you. Thank you for that. And again, the Workforce Committee will obviously work closely with the executives on the results of the staff survey, as well as encouraging the process. Chris Gone.
Oh, thank you, Chair. Thank you very much. And thanks very much, Philip, for your report, which I think is absolutely brilliant. And I mean, you talked a lot about the number of sickness. I mean, we're looking at a figure of around 400. And my concern was that we have got those people who have been working from home. Do you know what sort of percentage of those people working from home, and what is their kind of support do they get in terms of sort of moral support?
Yeah, okay. So the people who have been working from home are the lowest sickness in our across the trust, and that's probably understandable. So it's highest in frontline ops and in the two call centre businesses, and significantly lower when you get to the corporate staff who've been working from home. What support do they get if they are sick? That doesn't change. That is exactly the same as the people who've been coming into work, and they have full access to our wellbeing hub, which and the range of services that are provided through that service, as well as the normal range of workplace health services, as well as and that's on top of being available to their own GPs and things like that. So I think they're getting good support, but I'll let Ali come in.
Yes, Ali?
Yeah, no, I agree with that. I think so the support is the same actually in the all the kind of services that we offer, and we have quite extensive services in terms of our wellbeing hub and other services like that. It's just so I think for the record, actually, the number of people we still have working from home in line with the national guidance is still over 400. And we do know, because we've done sort of like some regular surveys of people actually along the way, is that for the majority of people, the vast majority of people, actually, that they're quite liking the sort of flexibility. I think it was a hard shock at the start, I think, like in common with all parts of industry. But actually, as people have adapted to it and got used to it, actually, you know, we're getting very high 90% plus response rates of staff who would prefer to continue to working in a sort of a flexible way like that, so an agile way like that. So, and I do think that's important, because as an exec team, we're just thinking about you know, sort of work-life balance and health and well-being, and you know, how we actually manage that going forward, which is a common thing. I say it's not particularly it's not particular to the NHS. It's right across the industry. I think every industry is having to look at this at the moment, but it's an important part of our thinking going forward.
But working from home is not for everybody, and not everyone has got the facilities at home. So I think we need to be flexible in our approach on that. And again, if the Workforce Committee can work with Ali to ensure that there's appropriate scrutiny of that. So we do get feedback from our staff at work from home, and not all of them have enjoyed the isolation. And I think there's a particular imperative to make sure we communicate well with them in order to maintain their morale, because it's they're not so as to say, it's not for everyone. Okay, can we conclude on the Chief Executive's report? Thank you. We note the report. Thank you, Philip. Shall we move on now to the next item, which is the Better by Design item? And Philip, you're going to talk to us about this, the verbal update.
That's right, Chair. So you would normally expect to hear David at this point, and as well as me, but David has got a second lot of COVID himself, and so is unable to attend today. So we wish David Hammond well for his recovery, and hope that it's not an extended one. So I'm delighted to be talking about Better by Design, and for those who are hearing this for the first time, the board members, that doesn't include you, but for those people who are hearing about it for the first time, Better by Design is a portfolio of programs that will deliver the strategy that we set, and that strategy was translated into a strategic delivery plan. The strategic delivery plan, the outputs of that will be achieved through Better by Design. Better by Design, it consists of a series of programs that the portfolio program called Better by Design will tie together, because what we've noticed in the past when we've done strategic change is that some bits move at a pace that others can't keep up with, and so you get these disconnections, and that has unintended consequences, because by the time if you've made your decision that you're going to take 10 paces to the right, and someone else moves in a different direction, then you end up having to change it. So it's a very untidy way of doing it. So Better by Design will ensure that all of the programs that are set up to deliver stay in step and move in the same direction. So the really exciting ones as part of it. So the most exciting part of Better by Design is the redefinition of our care delivery model. Emma's got the privilege of leading that piece of work, and that's about doing more of our work from in a virtual way as opposed to a physical way, and using the skills that we are bringing in bit by bit into our control rooms, and the training that we're giving to people like our PPs, our paramedic practitioners, to be able to do more treatment virtually than physically, and once that's a key way, because we're all looking ahead and seeing the next 10 years and not expecting the money to flow into the NHS in a way that it has potentially in the past. So we've all got to do something about that. The systems are determined to try and decrease the amount of people that go from services like ours into the emergency departments of hospitals. And Better by Design and the care model that Emma's working on is our contribution to that. But it also, of course, enables us to do more with less. If we can get up to a significant number of virtual dealings in the next few years, then what that will enable us to do is to give is to treat those people that are still needing a physical response. We'll be able to give them better care, and we'll be able to do it in a way that we're struggling to at the moment, because we won't get over the demand and supply side of the ambulance problem. It will balance out more easily. There were going to, and if we hadn't had Omicron and David hadn't been away, who is the SRO for this programme that I'm sponsoring, we were thinking about launching it this month. We've delayed that by a month, so the launch will come after the board away day next month, and at that stage there will be a variety of things that we have already worked up, but which haven't been through governance and through process yet, but will have done by then. Such as we've all talked about a blueprint document, an overarching document. We've seen drafts of it, and that is ready to go. But with it comes simpler, shorter, more stylised versions for staff who don't want a 20-page document. They need something much clearer, so that their contribution can come from that. Elevator pitch help type documentation, communication strategy that we've worked up, that will launch as soon as we go past the board next month, and then there's a series of portfolio documentation plans. So each of the programs, each led by an executive director who's on the board. Each one will have a specific plan, and all of that tied together by a high-level portfolio milestone plan and a business case for resourcing this programme. So it's a very exciting time, but we're just shy of launching it. And so at this stage, I will say no more, Chair, and I'll hand over to you for questions.
Thank you. Well, the important thing is we've trailed it this morning because it is an important,
really important
procedure, very important for the work of the board and for the organisation. We wanted, and it's been talked about for some time, so it's important it becomes out in the open, but we also need to ensure that all the appropriate documentation is ensured is under the eye line of the board and is subject to board scrutiny, and is then obviously released as part of our public accountability, so people can see what the organisation is up to, as well as our staff, of course. I've got some questions coming forward. Michael, first of all, Michael Whitehouse.
Thank you. Firstly, let me preface by this saying, Philip, I know we've all been involved in various different stages of this project, and I support it wholeheartedly. Having said that, I think there are some risks that we need to be careful that we really manage. Now, all of us, not today, have seen various stages of the documentation supporting this. I would put the challenge to you. I think the language around engagement is not good enough yet. I think if I read this documentation, I know this isn't to the board, it still has that feel of it's been done to me. So the challenge I place on you, and I would get greater assurance if at that launch next month, I don't know if it's in the public domain or whatever, I'd like to hear from more junior staff what Better by Design means to them. Are they excited by it? Do they feel, somebody out in the operational field? And I do that because, you've got a lot of non-executives on this board who've got a lot of experience, but my experience is unless you can demonstrate that it means something to them, it will not be successful. That's my first point. My second point is around integration. I think it's really good the way you and David Hammond and Emma have clearly articulated the different components of Better by Design and how they need to be delivered, and you've got the accountabilities, but there is still the risk that it's stovepiped. And we talked about this, and my biggest concern is that there's proper integration, and I know you're thinking about the governance around that, and I would say that that is key for me. And then my final point is why I really support this is CCAM is not acting like a victim in this space. We are looking ahead. We want to be serious players in the South East health community. We've got a key role to play in addressing some of the issues around emergency care and public health. It's not just us. I know there are issues in all the trusts around capacity, but I actually think we need to be out there really talking about this, not over-promising, but getting real engagement from the sector so that they understand what we're trying to do and we get their support and buy-in. So those are my 3 points. Very supportive, but I still think we've got a bit of a way to go yet before I would feel assured that this is on the right path.
Yeah, thank you. So engagement, integration, and paying due account to the wider urgings of the emergency care system. So thank you, Michael. Can I take other comments from board colleagues? Anything else you want to add at this stage?
Paul's hands up.
Yeah, Paul.
Yeah, so I think it's getting there actually. But one thing that might help is we have a lot of strategies within CCAM, and explaining how it pulls all the other strategies together, because it's a sort of overarching one might be helpful. And some of the language is a little technical. That coming from a technical person, that's quite interesting. So making it just resonate with people a little bit more might be helpful as well. And some kind of timetable or indication of timing. I know it's very broad, but I don't think timetable's mentioned at all. But it is getting there. It is a lot better. So I think we're not far off actually. So thank you.
Okay. Thank you for that. I can't see any more.
Chris,
Chris, hi there.
Thank you very much, Chair. Thanks, Philip. I think it's very similar point that Michael has just raised, that how much engagement has there been involved with the, this project right from the beginning? I mean, were staff consulted or sort of their ideas sought to be involved as part of this? So it might be quite helpful to just maybe explain, and if there was that consultation with us members of staff.
Yeah, thanks. I'll pick up a couple of, so that's very, very close to Michael's first point. So the staff consult, the design of the care delivery model, which is the key thing. Everything else is there to deliver that, just about. And so that we haven't done a top down and said this is the care delivery model in exactitude. We've just given a guidance for we need to be more a greater percentage of our work needs to be virtual than otherwise. So the next phase, when we launch it, that's launching to the staff in the big picture. So of course there are members of Emma and her team who are talking about this, who are putting their ideas forward and all of that sort of stuff. But the big staff engagement piece is the first is the piece that comes when we start at the end of next month. So it's in that phase, because this isn't a top down. We'll get all that bottom up into the design, and then all the other bits of Better by Design are there to support and deliver that operational model. Emma, anything you want to say?
Yeah, Emma, can you give some frontline assurance into about engagement particularly?
Thank you. So I've absolutely had conversations with my team. I think we need to recognise we need to set some framework around this, because what we're trying to do, as has been described, is broad across the entirety of the trust. So it's been really important to set some framework and some expectations of a direction of travel. You allude to a multitude of strategies that we have. We need to absolutely make sure that everything, when we have these conversations, they are within the direction of that the strategy takes us. So I've had some really good conversations with my senior team at this point. As Philip has said, the next stage will be doing the launch with the wider groups of staff across the area. But I do just want to add, whilst we may not have been consulting in a formal way and engaging in a formal way under the Better by Design conversations, I'm out and about in operating units every week. My team, my senior managers are. I know Philip goes out every week. Please be assured we're testing and asking and saying to them, what is it that you want? What is it that you think? What ideas have you got? So when we are having some of our Better by Design conversations at a slightly more strategic level, we are bringing this information that we have been accumulating over the months and years and thoughts through all the different engagement we have. It may not have been put under the umbrella of Better by Design, but it absolutely comes through in the conversations that we have, both on one-to-one basis with all of our staff, not just operational staff, but with our fleet and logistics colleagues, everybody involved in running and delivering in this organisation. We do have regular discussions with them to seek their thoughts, seek their wisdom, because we all know that some of the best ideas of how to make improvements come from those people who do it every single day.
Can I just finish off something before you go to the hands? And the voice that comes from our staff speaks a different language normally, and in most cases. So when I'm talking to staff, and I know when you, the non-execs, have been out, you've heard exactly the same thing. The reason why the key is this care delivery model is so brilliantly illustrated by what I hear every time you talk to a group of paramedics, and that is we go to too many they sometimes say rubbish jobs, and there are jobs where we really shouldn't be sent, and that in one piece of feedback which we all get is the driver for virtual for solving things virtually. So it connects really cleanly to what they've told us that they're unhappy about, and they want a way of doing it, but they may not call that a care delivery model in that sense. So I'll leave it there. We've got hands up, Chair. We've got David and then Howard.
Yeah, Howard, then David.
Thank you. Yes, I still struggle with this word blueprint because, as I've mentioned before, blueprint to me implies that is the answer. And I'm just worried that people will just interpret that as the answer. And I don't know whether Chris, had interpreted it in that way. What it is, I think you're referring to, is a blueprint for the process rather than a blueprint for the end result.
Yeah.
It's just that word is at risk of being interpreted as, well, you've just come up with the answer then. And then suddenly everybody's offside. I think the engagement point, Chris is nodding, the engagement point, I think, is great, Emma, that you and Phil and so on are getting the feedback. But what's even more important, I think, is the facility and the ability for some key champions within the organisation to facilitate that debate within their teams of junior and to generate those ideas themselves. So in addition to the great work you're doing, we need, and I'm not quite sure whether that process is in place as part of it yet, just because obviously we've been out of the loop with David, or David's been out of the loop a bit. But to me, it's critical. The engagement is those discussions within those teams led by champions who could be anybody, junior people who are leading those discussions and debates and coming up with the great ideas, as you say, and then feeding those upwards. And that should be done on a massive scale. It's not, the number of people you can get to, with respect, it is not sufficient to get that real embedding of the engagement across the organisation. It has to be led by teams, many 20, 30, 40 champions across the organisation, engaging then in turn 10 or 15 people to facilitate those debates and come up with their suggestions and their ideas. And then suddenly you get this massive flow of suggestions and ideas that you then have to filter and so on and so forth. That is the engagement that I think we need. And secondly, the other point is that there are some quick wins here as part. I know the care delivery model is critical, as you say, as part of this, but the performance cell is actually, as part of Better by Design, is reasonably well advanced, and that could be demonstrated to be a bit of a sort of quick win, if you like, and is delivering results already. So it can be sort of shown as this is part of the Better by Design. I know that part of it hasn't had perhaps the engagement, but it's a slightly more technical aspect, but it is nevertheless part of Better by Design that can be shown as being, delivered, well done.
Shall I pick up the second part of that? And yes, as I said, there are real things going on already and have been going on. And since we wrote the strategy, they all come out of the strategy. We're now formally having them as part of Better by Design, and the continued development of that planning and performance measuring and predictive analysis, etc., that we didn't have this time last year. It has changed the way in which we do our operational planning, and we're using it already, and it's a great thing. And those and yes, it doesn't come from lots of staff engagement. They didn't say that's what we needed, but when we've talked to them about it, they're going, "Wow, this is what we needed." It's getting really good feedback.
Because David's he's our expert in this area. David.
Yeah, thank you, and thank you, Chair. I'm going to pick up on a couple of points that have been raised, and I think all of this discussion is really good because you're picking up on all of the red flags when we go into a large-scale transformation. I'm just going to add one more red flag that as a board we need to be aware, which is speed of change and making sure we don't promise things we can't deliver in a timeline that people will expect. Because if we start talking about promising the world now for a transformation that may take several years to complete and deliver, we may let people down. So when we go into this transformation, it's very important that our communication strategy, it's not only us as a senior team leading it, but it's at all levels of the organization we have, and you use the word champions, Howard, which I'm a big fan of. so that people live and breathe it, and there's a conduit. We don't have a sensation that there's been 2 to 3 months where nothing happens, because we're going to lose the pace. And we just need to caution when we think about comm strategy and we think about how we start to talk about Better by Design properly after we launch it. We need to be able to live and breathe it and maintain that pace for a number of years and demonstrate that there is a significant advancement in the program, because otherwise it's very easy that we will take away things to a very technical aspect that people won't see for 6 months. And then 6 months is an eternity if somebody comes and tells you we're going to fix the world for you. And we need to be able to hit the right balance of communication with staff there. On the performance cell piece, it is very technical, but there's no point in me going away with my team doing something technical that Emma's team don't buy into, because then we will not deliver at all. So we are, as you know, building, the initial stages are technical, where we're building the technical capability and the capacity. And we've done this, I know it's in your performance committee report, Howard, around building those simulation tools that will help us test the answers. But the key before we get that technical piece completed, which is about getting the systems, is the work that we want to start over the next couple of months with Emma's team around working with the operations team and the medical team. And it's not only about, it is about the care delivery model, but it's delivered, as we know, across CCAM, not only within operations, as to how do we deliver that model, because parts of it also linked with clinical education, parts of it also went to impact how we think about our fleet, how we think about our estates. So being able to do that effectively fact-finding mission up front, so we know what is it that we want to be testing, because effectively those care delivery models are the ones that then we're going to be effectively putting through the simulation tools that we're procuring, which is the technical aspect, but it's so important that we test things that are relevant, not things that people don't recognize. So just a couple of points there as to, because that's the piece of the performance cell that that's the real part that we're doing now for Better by Design, and we are just tipping from building the capability and capacity into starting to be in a position where we can engage to get the facts and build the scenarios that we want to then test. But we need to bring people along with us, and it's not just going to be done with 2 or 3 people sitting in front of a computer. 100%, we're not going to let that happen.
Thank you, Dewey. Thank you. Michael, final question, and I'll summarise.
Yeah, my point is this. Our role is to challenge, and I hear what everybody is saying, and I'm 100% behind this. I'll just repeat what somebody said to me once in my career. You think you're engaging, but in fact you're not. And the challenge I would give to you is, next time, Philip, you and your colleagues, and I mean this very positively, are in a closed room, sit down and really challenge yourself. Am I really engaging? Because I'm struck by the point that Howard made about blueprint. Most transformations I've seen have been successful. The point at which they launch, that engagement has already taken place, and what you find is that people hear it and they feel really empowered, because it's what they've already told you. They feel that they've been active. That's my first point. And my second point is, the moment you launch this, and it's really David's point, the clock starts ticking. People will want to see results, and I think it's really important that if I'm a paramedic, if I'm working in 111, or if I'm working in 999, look at it through their perspectives. And what benefits do they see? How relevant they are? I'm long enough and old enough in the tooth to remember NP Fit. This is the major NHS programme nearly 15 years ago about the NHS and IT. And they made a fundamental mistake. The people, if there were any early benefits, the people who saw the benefits were the people who operated in the back office, not the clinicians, not the nurses, not the frontline staff. So they were immediately turned off by the whole programme. So all this, but I do think a quiet reflection before next month, and be absolutely certain you really are engaging and you've got that right. But really 100% support for it.
Okay, thank you. In summary, clearly, sorry, David, do you want to come back with a final word? Sorry, in summary, clearly very exciting but important programme for developing the organisation, particularly the quality of our patient care and our staff experience. Absolutely crucial. So unfortunately, we don't have the documentation today, but I think there's good reasons why we have not got that, because of clearly the operational challenges, but also illness of key staff at this time. But I think it was important it still came to the board today, because it's important that the organisation realises the board are behind this programme. This is not just something that's going on in isolation, and the board are setting clear parameters for success criteria, and what the board are saying, particularly my non-executive colleagues, are making clear, good evidence of engagement of our staff, absolutely crucial. That we're going to be listen again to make sure we're getting their ideas, we channel their ideas, and make sure we can turn them into practicality. But also, it's going to be set against the reality of the world we're now working in, hopefully the post-COVID world, but the constraints the NHS is working in financially as well. So we've got to deliver service to our patients and live within our means in a health service that's really strained. So this is a sort of trailer this morning in recognition of a more important launch, and then it's important again we share when we are in that position that our public, the staff and others get full visibility of what we're doing. But the board this morning is right behind this, but we're putting our clear markers down now about how we want to see things done in the future. That's engagement and integration. Okay, thank you. Let's move on now to the next item, which is two important enabling strategies which support better by design. The first one of which is the clinical education strategy, which is a very welcome paper this morning. So Fiona, are you going to introduce this?
Yes, thank you, Chair. Good morning, everybody. I would like to introduce the clinical education strategy by introducing Ashley Richardson, who is our consultant paramedic leading on clinical education. Ash joined the Trust 11 months ago, and one of his major objectives has been to develop the clinical education strategy, which is now being widely consulted on. It's been to QPS and it's now coming to the board for approval. So if I could introduce Ash, please, Chairman.
Good morning, Ashley. Welcome.
Good morning. Thank you very much. Thank you for the welcome, Fiona, and hello, board. So I've been asked to come and present to you the clinical education and training strategy that has taken some time to develop, but in collaboration with colleagues from across the organisation, spanning all directorates, from frontline clinicians through to executives and non-executive directors. It's been a journey where iterative versions have been shared, and individuals in this forum have contributed to that journey. So this strategy, importantly, is an enabling strategy, or I see it as an enabling strategy for sustainable CCAM, our corporate strategy. And what it will do is enable us as an organisation to have an industry standard, recognisably industry standard, clinical education and training department that is there to serve all aspects of the organisation and support good governance in education delivery. Those of you that are aware of the Health Education England quality framework will absolutely see that this strategy has been developed with that in mind, and it aligns explicitly to that. And for me, that is really important because it should be a document that means something to anybody, including our external stakeholders. And in the event of us delivering Ofsted sort of accredited training, will be recognisable to sort of regulators too. Our intent, assuming you are satisfied and we're able to release this strategy, is to utilise Better by Design as a vehicle to enable us to implement the strategy and drive through the changes. A delivery plan has been created that has time-scaled steps over a 3-year period to ensure that we deliver this strategy, and we'll be utilising the current governance forums and mechanisms to monitor progress and to provide assurance up to the board. For me, strategies give you a roadmap and a direction of travel, but it needs to mean something to our colleagues, to our staff. And I fundamentally believe that by delivering this strategy, will open up a positive learning environment for our staff across the organisation that will enable an individual experience, and for us to enable our staff to reach their potential, whatever that may be, and for us as an education and training department to flex to the sort of changing needs of the organisation. So I'm going to pause there and welcome any questions that you may have.
Thank you indeed, Ash. And just before I just up to questions, Subo, from the point of view of the Workforce Committee, I know this has had appropriate discussion through that forum.
Absolutely, thank you, Chair. You anticipated me, so I was just going to say I'm standing in for Laurie as Chair of WWC today, and we did see this. We've seen 2 drafts of this, and we've had an opportunity to talk with Ash about a lot of the detail. Tom and I also visited Hayward Heath as well, where we talked about it some more. So we've had quite a lot of input, and Ash has been very kind and very patient with us in listening to our questions and concerns and incorporating a lot of those in. So we're delighted that the strategy has now come to board in this final format. So well done, first of all, and thank you very much for taking on board all of our comments around apprenticeships and some of our concerns around how that would be built in. And as you rightly say, it's so important because it's about the talent pipeline. It's about how we get people into this organisation, how we develop them along the career pathway, and then how we then assign that workforce. And it couldn't be better timed, given that we're doing better by design. So this is a very important strand of that kind of transformational work. I know David and Emma and his colleagues have worked very hard on putting together and starting to pull together details around the workforce plan, and we were delighted at Performance Committee to see a lot of that starting to come together. So I think between the 2 of these things, we'll get a really good feel and sense for what that should look like going forward. I think our challenge to you would still be something broader here around exactly where this will sit overarching around education and training for the whole workforce. We know that we discussed this at WWC quite a lot. We want it to have a home, and I think that that's picked up in the escalation report here for WWC, where we talk about the structural matters around how all of education and training will sit together, because we know that our workforce, it's not just about their clinical education, it's also about leadership and management education, statutory and mandatory training, and all sorts of other things that we think is important. So we want to see that under one coherent whole that sits in one place. So that will remain our challenge to you. I know you'll be coming back to WWC further with some thoughts on how that structure is going to work. But first of all, well done on bringing the strategy here. That's a big step forward for us.
Thank you. Actually, you told we come back with some closing comments towards the end of the discussion. So there's 2 questions I can see, David, and then Michael. Questions or comments?
Thank you, Ashley, and thank you for bringing this to the board. As you know, I'm a fan because what this does, it's a nuisance point, but I'm going to contextualize it in the context of better by design, which is this increases our ability to internally retain talent because we're quicker at getting people to a higher level of a technician, effectively, of being able to deliver care. And that is something that we know is the reason why people leave, so we're able to retain that in-house. My only challenge here is, this needs to be hand in hand with the workforce, and we need to make sure that through the structures that you're putting in place, we're able to respond to the needs of the workforce. So this makes the engine bigger, makes us go quicker if we want to. And then I think the key thing is understanding how quick do we want to go in terms of being able to hit our target workforce, which is part of the work that we're doing as part of the performance cell. And I know this is still at inception, but just from a board perspective, this is how this fits the overall picture, which is by itself, this just gives us flexibility and the ability to go to where we want to go to. And then we do the work to define where is it that we need to go to. So not just because we have more capacity to train CSWs as an apprenticeship, means that that's the target solution. It just means that we have the option should we want to. So I think it's important to put that into context as to how this fits with some of the discussion we've been having around better by design and being able to hit our target workforce more effectively. My only second comment and chance for you, Ashley, is the transition to paramedic complements that we get as an example. And I think I said this at the board in November, is if we were to put a net promoter score to some of those comments, I think we would score incredibly high. I think we would be up there with the Nikes and with the Apples and with the Amazons of the world. So for me, this strategy is about what can we learn from what's being done there to other areas of the business, because we know that is a really good thing, but we know that that is a challenge in some other places. So how do we use the clinical education as a conduit to increase what is called a net promoter score across other areas of the business?
Okay, thank you. So well made points there, David. Thank you. Michael?
Thank you. I don't think I was first, but very, very quickly. I'm interested in what Sue said about the integration point, which is key for me. So What's the money flow here? That presumably, Philip, I know David Hammond's not here, there is a budget for training and development. Is medical education a subset of that, or is it part of it? Does it stand alone? And I'm interested in the accountability, how that flows up, because that would be, so, you know, from a purely accounting perspective, and I'm sure Howard's the same, I'm interested in what is, you know, what does it cost to train a paramedic? Does it cost to keep a paramedic up to speed? And are we investing the right level of resource? And I don't think it's always been as transparent as that as it could be. But I should have said, Ashley, I really welcome your report and nice to see you here today. But Philip, is that a easier question for you as accounting officer, or is it Ashley?
Probably the I'll ask Phil to come in on that one. But
yeah, funding for clinical education is a sort of combination of what we receive from Health Education England and what we invest ourselves in the infrastructure, because Health Education England don't invest in infrastructure per se; they invest in programs. So we have that sort of mixed model of funding for the service. Yes, there's a devolved budget for medical education managed by the medical directorate, and that is, as I say, essentially used for infrastructure. And if there's any need to invest further, then that goes through normal sort of business case process. I'm not sure if that fully answers your question, Michael.
No, but my only, you know, the assurance I'd like going forward in the next financial year is, you know, when we look at the budget, I think it would be good to look at training and development in its entirety. Not because I want to cut anything, that's not my job, but I want some assurance that we've got the resources right, because as Sue has said, there's a lot of challenges here. We've got to invest in management development. Clinical education is clearly important to patient safety and staff development, but I'm not sure it's as transparent as it could be in terms of the resource allocation.
But I think that's a point we'll take away for further action. But also I think to know this is an area where the trust was significantly challenged in terms of our basic education of our clinical workforce, and I think you know, commend Ashley and the team for the way we've responded, and we are now beginning to make a comeback, as it were. And in terms of getting, I was really pleased to see, I think it's a Facebook post yesterday I read about our examination results through Crawley College, where we've seen a number of commendations which our technical staff have received, which I thought was tremendous to receive. But I think the point the board is making is this must fit in with a wider suite of other policies around our developing our staff. But obviously it must be financially visible as well. But thank you for that. Other comments, Emma?
Thank you, Chair. Just building on a comment that Suma made earlier as well. I think, Michael, your question about the funding and how we spend it to make sure that our staff are trained initially and then maintained and grown is a really fair one. Ash, myself, and Yvette from LNOD, who's our head of LNOD, she is working with us to look at training as a whole. So what that entire pipeline looks like, we've done a really big piece of work that we did present at WWC in December. It's coming back next month, where we looked at about 80 plus courses that are run across the trust each year that meet both legal requirements such as command training under the Civil Contingencies Act. They meet license requirements such as NHS pathways, a whole range of things that sit under management, and obviously that which sits under our core skills training framework under NHSE, HE, etc. We are working to plan this in a much more structured way that is based on role, so that we meet the needs of each role. But actually we also are looking at it not on an annual cycle, but we're currently talking about a 22 to 25, so a 3-year cycle, to not only make sure that staff get what they need, but that we use the capacity as effectively as we can, so that we are much more sighted on the breadth, as you've just described, of the totality of the pipeline to bring people in, but also that ongoing growth, because it's also about how we grow people for promotion, and how we support them to retain them longer. So all of this I think will have a positive impact on retention. But I can only say it is It's one of those things that when you start it starts mushrooming, and it's been getting bigger and bigger. As I think Suba and those at WWC saw, but I do think we're in a much stronger place than we've been. And I think Ash doing this piece and setting the strategy and doing the work around the pipeline and then linking in with this longer piece around when you're with us, what that looks like. I'm sure we'll be able to provide the board with further assurance and updates going forward as we take it through WWC. And also, of course, it will innovate into the performance committee.
Yeah.
And it will innovate into other committees as well, such as FIC, because fundamentally for me, this is about how I create the abstraction ability to be able to provide staff with this training as well. So it's a massive job that we're working on at the moment.
Okay, thank you.
Before I ask Ash and Fiona just to conclude, are there any other final questions at all from board members?
Yeah, I have one, David. Sorry, I left my hand up for a while.
Your hand raised, Tom. I apologise. That's why I'm asking. I see one hand, but I'm not sure who it is. So, Tom, come in.
Thank you. A number of things. First of all, congratulations, Ash and team. This is a really, really good piece of work, and it's very timely. So, thank you. Just one thing for Philip Astel for clarification. We're not talking about a medical education budget. This is a non-medical education budget. It's a horrible phrase, but medical education is a different funding stream for doctors. But really, I just want to sort of expand on what Subo and others have said about integration with everything else we're trying to do in terms of our developing our staff. We have hundreds of registered nurses. We have other registered health professionals employed by the trust who are not going down the paramedic route. So we do need to think about the continuing professional development and ongoing development of those colleagues. And I'm just wondering, that's out of scope of this strategy at the moment, Ash, is it?
No, I would suggest it's not. So there has been feedback received surrounding the need for this strategy to reflect a multi-professional clinical workforce, and that's what we've tried to do. So I've removed terms surrounding paramedic development and integrated terms such as multi-professional. And in my mind, what this strategy will do is start to enable us to look to bring wider clinical education training governance into one place, and that will break down previous silos between EOC, frontline field operations, and enable sort of this overarching piece. What I'm not saying is clinical education. My department, clinical education training, will take on responsibility for all of that. But I think the overarching clinical governance and the platforms of educational rigour do sit with myself and my department through this strategy. So I think it's going to be a good thing in working more collaboratively across directorates, across departments.
And it's really good to hear that. Thank you very much. Thanks.
Thanks, Tom. Ash, Fiona, any closing remarks you wish to make?
So, Chair, I'm just conscious that Chris, Liz and Ali have all got their hands up.
Sorry, I can't see that on my screen, actually. So, yes, thank you, Chris.
Thank you very much. It is just, I'm just going to say, Ash, I think this is excellent piece of work, really good. And I mean, it excites me really. And I think the thing, I'm just going to pick up on Tom's point, that I think at the end of the day, we need to make sure that I think this strategy encompasses those individuals who really don't fall in the paramedic. I mean, it matters because we want to make sure that we are trying to retain all people working for the organization, and we want them to progress and we want to develop them. So I think we should continue really hammering that message so that people don't see it. It's very specific to the paramedics. So that might be very helpful.
Thank you. Ali?
I think Liz was first, but if you're inviting me, I'll go. So
sorry, I'll see the other hand one, so I can see yours now. So Ali, come in.
Yeah, no, sure. Thank you, Chair. So just to sort of add a couple of points to what's already been said, I think, and also give a sense of timeline here as well. So with obviously fully supportive of the clinical education strategy, and we've been through it multiple times and etc. And I think it's an excellent document as well, and it's a really big step forward from where we've been. With the management development work and with the key and core skills work as well, we've committed to getting our plans in place for those for the new financial year. So we're working on those as next steps as well. And then we've also committed to putting the educational governance structure in place from April as well, as an exec team, and that will report to EMB as the Executive Management Board for delivery and assurance to the Workforce Committee. So I do think we'll be a lot further forward in terms of the way that, as opposed to where the trust has been in the past. We are conscious, I think, actually, is that we are building the overall approach. So to the core of Suba's question, I think, is how does it all kind of stitch together? I think we are conscious of the fact that we're actually building each part as it goes. And there are multiple other dependencies as well, such as sort of estate strategies and communication strategy and IT and other things that we do as well. So I think what we do is, I'm sure that as we get the education board up and running, actually what we do is we'll actually build all of those different elements into that, so that probably in 12 months' time, I think, we'll have a much more comprehensive and overall answer to the core question I think was being asked.
Thank you. And there was one more question.
Liz.
Yeah, thank you. Thanks, Ash. I think it's a fantastic piece of work, and I think it set the framework along with health education framework for our clinical education strategy. I think I'm along with Tom wanting it to be explicit. It does cover our other health professionals, as from nursing to our pharmacists, etc., so that we do have that entry level and apprenticeship, but also that career ladder and pathway to our senior clinical leadership. And as Emma said, maintaining and retaining our staff, but growing and developing and keeping our talent within the organisation. But I think it does have set the framework that we can further expand to cover our other areas. So thank you for that.
Thank you, Liz. So Ash, Fiona, any final words before I quickly sum up?
Just from me, Chair, thank you all for the support for approving the strategy. That's really helpful. We'll take away the other comments, particularly the ones around the multidisciplinary training. But I think now it empowers Ash to take forward the practical aspects of the next steps that he's got to enact, and that will allow us to take business cases forward in the next month. So that's really helpful. Thank you very much.
So Ash, as you've heard, the board have enthusiastically endorsed and approved the clinical education strategy with a few amendments, as it were. And I think just in terms of making sure it's an integrated document for our clinical workforce to reflect what Better Bodies Arnie is trying to bring about, which is an integrated clinical workforce providing integrated clinical services to our patients. So that theme is we're asking that emphasised some more. But can I just say on behalf of the board that thank you for your efforts and that of your team in particular, because I know you've taken on quite a challenge there with clinical education, the way we did our difficulties, and particularly with external accreditation. So thank you for what you've done, and we look forward to continued reports through the Workforce Committee of the continual progress, continual improvements in this area. So thank you again, and thank you, Fiona, as well.
Lovely, thank you.
Okay, thanks indeed. So let's move on to another very important enabling strategy before we take a short break, which is our green strategy, which I think David, you're going to introduce.
Yes, thank you, Chair. And so the green strategy that you have in front of you is the first step, the very first step of the journey we want to go down to becoming a sustainable, from an environmental perspective, sustainable healthcare provider. A little bit of context to this may be helpful. Aviation worldwide is 3% of emissions. In England, healthcare is 6.5%. Obviously, aviation is a bit higher, it's about 7% in the UK. So when you think about our footprint as a healthcare provider in relation to some of these other big industries, and I think reflecting of my past career in aviation, how much effort we put into environmental, we had reams of environmental teams in the aviation industry. We have a long way to go as an organization to put ourselves in a position where we can say we have plans in place to deliver against the targets that has been set. Those targets, which are landed in the paper, say that we need to reduce our carbon footprint and our emissions by 80% between 2028 and 2032, depending on the bracket that we fall, and we need to completely become net zero for direct emissions by 2040, and all of our emissions by both direct and indirect influence need to be zero by 2045. when you think about the type of operation that we run, where we drive 15 million miles a year burning diesel on 3.5 to 4.5 ton trucks, that will be a massive undertaking, and it will impact everything we do from a infrastructure point of view, from our estate, but also from how we conduct our operation and the savings we can achieve there. So what this vision, what this strategy does is it sets out a bit of a framework that fits within what the overall NHS Green Plan and net zero ambition is. However, it's only the first step, and you will see in the paper it's very clear about there's a follow-up step about developing a plan, and that plan needs to be much more specific than what you're seeing here today. What you're seeing here today is around the strategy, but as a board agreeing on the direction that this is the right thing for us to do and to be ambitious in our net zero targets. However, there is more work to be done to then convert this into something that has a robust plan that tells us what does our carbon emission makeup look like, where are emissions coming from, what are the low-hanging fruit areas, what does the profile of investment look like over the next 5 years to get us to that 80% reduction by 2028. And that is the piece that I'm just going to draw attention to, which is the next step that we need to do. We are talking to a number of organizations, both academic and non-academic, around how we can get external support to achieve this, because we do not have the in-house expertise to pull this quantum of plan together. And it is something that we will be coming back to the board with more detailed plans. I would draw attention, though, to a number of things that we are doing, and this is the dichotomy of this plan, which is we are doing a lot of things, but I can't at the moment quantify how much of an impact those things are having. So we know that we are changing our lights. We know our make-ready centres are BREEAM very good, which is a big saving. We know that we have a plan for rollout of electrical vehicle charging stations at our estates, and we are installing some photovoltaic panels in a couple of areas, but we don't know what that is giving us back. There are a couple of changes we are introducing from next year, though. So we will introduce a 10% weighting to procurement to all of our procurement from 1st of April, and from 1st of April we will source 100% of our energy from green renewable sources. Again, that sounds very good, but I cannot tell you how much of an impact that is having on the overall, and that is the piece we need to change when we talk about a board, as to how we have a plan that is quantifiable and gets us to hard targets rather than just doing things that sound good, but we don't know how much of an impact they're doing. As a final comment, I would like to say we have just yesterday signed up to our first 3 electric single response vehicles, so our first 3 ambulances, which we will be receiving sometime in the next quarter. And this is part of a trial of a net zero emissions pathfinder that a number of ambulances have bid for, and we have been one of the few that have been successful. So we will be reporting more on that as and when the trial develops. But that was a good news piece of work that was completed yesterday, and that we're not going to be starting.
That's a tremendous piece of news. Well done. That's a way to get the board excited. We like to be innovators, we like to be at the front. So well done. But in terms of the plan, I think what you're saying, as well in introducing this, I understand you correctly, David, we still yet to see a delivery plan, and that will we need to work in partnership to ensure we have a clear plan of clear objectives, and a plan of the timescale is still to come. But it's understandable we need to get the strategy agreed first. Exactly right. Today's about the strategy, and as a board, this is something that we and an example, Chair, I'm going to give is we ask about quality impact assessment. We ask ourselves about equality impact assessment. We talk about financial business assessments, operational change. We never talk about environmental impact assessment when we make decisions. So as a board, this is about how do we change our mentality. This is not something we do because we're told we need to do it. This is something we do, and we evaluate how decision making is a result. And it's a changing culture at this level. And if we have that buy-in as a board, then I can go away and we can put a plan together that we can then commit to financially, time-wise, and organisationally over the next. Obviously, this is going to be a number of years before we get there, but we need to start now. I think as a board, we've got to believe, we believe in this. We're not just doing it because the NHS Centre has told us to do it. This is something all of us, actually, part of our values and beliefs that we think is really important that we do for wider society. So questions, comments from the board? I can see one hand raised. I'm not able to identify whose hand it is.
That's Howard.
It's
Howard.
Mine. Thank you very much. No, thank you for this. It's really great. Well done for putting it forward. It's an area, as you know, quite close to my heart. I was involved in Prince Charles Accounting for Sustainability project So I'm very, very keen on this. You mentioned the environmental impact assessment about a year or maybe longer ago. I wanted to put that into the business case template, and I haven't seen that happen yet. So can we please, as part of the delivery plan, make sure that every business case we have has, in addition to the equality impact, as you say, and the other impact assessments, as we have the environmental impact assessment as a matter of standard. It just appears in the template and then it doesn't get forgotten. That was only my suggestion, but well done. Fantastic. That's great.
Thank you. Any other questions and comments?
Yeah, I've got one.
Please come in.
Okay, yeah, there's a lot of work here, David. So I just wondered if you had enough. We're doing a lot of the right things, there's no doubt about it. I just wondered if you had enough resource to actually help move it forward, because a lot of organisations have a green manager and they've had them for a while. I just wondered if we had any thoughts in that direction.
Nowhere near. And I'm going to qualify that in a second. So from our ERIC returns, we know about 50% of the ambulance trusts across the country have appointed a waste manager and an energy manager. We don't have that position, and that's usually somebody who spends more than a percentage of their time focused on the management of waste and energy, but we don't have that as an appointed person. So that's just a gap that we know we are starting to fall behind against some of our peers. But at the same time, we are talking about a potentially multi-million program of investment over the next 6-7 years to get us to where we need to be by 2028. And the issue is, notionally, I can say we don't think we have the right resource. I don't think we have the right resource in the first place, or the technical capability to quantify what that work needs to look like. And that's the next step for me, is to engage with some experts. There's some people who do this very, very well and understand the issues very, very well, who can help us quantify the sources of our emissions, and then quantify and help us put a plan together that gets us there. And that will show us then stuff like profile of investment, capital over time, and then that will draw down the resource. But initially, Paul, this is something that we're looking to get some external help to quantify and qualify. And then we can, as a board, take a view as to what's the delivery plan resource requirement look like over time.
Thank you.
That was it, Tom.
Thanks. Yes. Thank you, and thank you, David and team. And very much like colleagues have said, I really like this. Just a question, just for clarification, really. So CCAM already submits quarterly NHS Green Plan reports, including on medicines and things. And I'm assuming that in doing that, we haven't identified any areas where we need to particularly focus on medicines and medical kit and medical gases, because they don't appear in the subsequent strategy that's presented here. So is that the case? Is that we're assured that around our medicines use and medical equipment use, we're not identifying areas that actually we really could improve on and therefore form part of this strategy?
So I'd say, Tom, they are, the paper is very biased to fleet and estates, but as we know, anesthetics and medical gases are a big source of carbon emissions. Potentially not as much of acute, but I may let Fiona come in and qualify that, because my understanding is limited. It is part of the green plans that we do need to submit, and this is part of where I'm very keen for somebody to come and tell us what, as a relative proportion of our emissions, that is, because at the moment I can't quantify that, and we may think it's a big issue, but it may be that it's 0.5% of our emissions, and therefore there's some other big stuff we need to be focused on in the first place. And that's the piece that I can't qualify. If I can't qualify it, I feel really uncomfortable saying we need to focus on it more than we need to focus on something else.
Yeah, thank you.
Thank you. And Fiona, do you want to come in and qualify on the clinical aspects of this?
Yes, thank you, Tom. The big issue here, Tom, is around Entonox, which is completely amazed me. I had no idea. And Entonox, of course, is a core part of our pain relief strategy. So we are looking at that and whether there might be other alternatives that we could use.
Thank you. Howard, is that an old hand I see from yours?
Yes, it's an old hand, sorry.
I can't see any additional questions. I think just in terms of summary, I think, first of all, I think the board are very pleased they need to endorse the green strategy. I think we've had some good enabling comments as well in terms of ensuring that we obviously its scope is widened to some extent regarding the clinical aspects of our work, but nevertheless we commend what you've already done to date. We also commend the fact we're going to be part of a trial for an electric powered ambulance, which I think is going to be put in the forefront to evaluate these new technology, which again we welcome. And I think what I'm also hearing from the board is general enthusiasm about this subject, and we're all citizens of the UK as well as members of this board, and it's something which is of interest to all of us in terms of both long-term sustainability of the planet and our working environment. So it really is an important topic. So we're looking forward to coming back with further enabling strategies as this progresses. Asking is the Finance and Investment Committee, Howard, under your leadership, which will keep a close eye in terms of developing this strategy, ensuring it's delivered against appropriate timescales. And clearly, David, there's more work to do regarding ensuring this area is appropriately resourced. And I think we're going to be looking for the cost benefits of investments in this area in order to not only save from a financial point of view, but also how do we capture that in terms of carbon footprints, etc. going forward. So that's going to be an important calculation. So I think on that basis, I think we can close that discussion. It's now 11:40, exactly on time as we predicted in the board timetable for the board to have a well-deserved break. So I'm proposing that we take 10 minutes to make ourselves comfortable and be back ready to resume again at 11:50. Okay, thank you.
Thank you.
To receive and approve the patient safety strategy. And I think, Judith, you're going to introduce this.
Yes, thank you, David. What I'm actually going to present is a presentation that has been asked. There's a national ask that it goes to every board. So this just sets out the national direction of the national patient safety strategy. I have to start with an apology because really it should be our patient safety specialist Tammy Moorcroft presenting this, but she's been unwell, and all our hopes that she would be back in time were foiled really. So but we felt it was so important. I'm still presenting the presentation. So the National Patient Safety Strategy has been under development and actually under pilot for some time. And I don't know whether you can see the slideshow yet. That would help, wouldn't it? I've got a slideshow, but that does stop me seeing hands. So if somebody could shout, if somebody puts a hand up, that would be really helpful.
I'll do that for you, Judith.
Yeah. Okay. Are you able to just see one big slide? Because I'm not sure what you can see.
We can't see you or the slide at the moment.
Oh, right. Okay. We'll try again. Oh, it says only meeting organisers and presenters can share. I don't know whether somebody else could.
Judith, if you start, because we all do have the presentation, and then in the meantime we'll try and get it out.
Lovely.
Judith, you can try now. I've just made you a presenter.
Oh, lovely. I'll try now. Thank you. Hopefully is that better?
You've come to this. Yes, we can now see it.
You can now see. Lovely. Okay. So just a very quick, I know you've seen the slides, so there'll be some I will go over. I will go over quicker than others. So just the purpose, I'm just going to talk about the key national priorities and underpinning elements and the elements in CCAM, but I will talk a little bit about system-wide implementation, because the difference with this strategy is it looks at patient safety across systems, which is really important and really positive for patients. So it really does quite revolutionise how we think about patient safety. We've historically looked at things that go wrong and then aim to learn from them. It really is about maximising things that go right and minimising the things that go wrong for people. Accept that it's human to make a mistake, which has certainly been a journey we've been on in CCAM for a number of years now, and reducing the potential forever. And there's two strands to it. One is patient safety culture. that I will touch on briefly because I know the board's already discussed that, and a patient safety system. But it really changes how we approach safety in terms of investigations, the lessons we learn, the involvement of patients in our safety culture, which will be absolutely crucial, and system-wide learning. We know that the safety strategy cannot be delivered with within one organisation alone. At the moment, organisations all focus on their own internal learning, their own safety, but we know that there are significant opportunities across each ICS network to change from that organisational delivery of patient safety to a system approach with a vision of minimising harm. And I think that really, and this trust gives us real opportunities to really improve patient safety. Very often when we look at particularly our serious incidents, we look at patients that are kind of at the end of a healthcare journey. And I know within the governance framework for 111, we do look at some patient pathways, but this really gives us the opportunity to look at patient pathways and look at how we might have changed the outcome for that patient. But it's also really efficient because we can pool resources. We can learn quickly from each other, from different organisations, both in terms of implementing the strategy and also in terms of lessons for patients. And it's quite an innovative approach. It's built on the 5 pillars. I don't intend to talk about all of these in huge detail. What I will say is there are 5 programs that you wouldn't think necessarily linked to CCAM directly, and in particular mental health, maternity and learning disabilities and old people, that we will obviously be working with other organisations as part of those programs as appropriate. It's got a number of priorities which are up there, and if anybody's interested in following up more, we've put the links to the documents on that particular slide. Just very briefly, it links to the Just Culture work that we are already doing in the organisation, and I know the board's already had a session looking at Just Culture, so I'm not minimalising culture. I just don't intend to spend a lot of time on Just Culture this morning. But there are other elements that we will need to consider as an organisation and are already starting to consider. There is a new national patient safety training syllabus, which is expected that whole organisations up to and including board will do the training. We're looking at how we would roll that out. And it's kind of at appropriate levels, but the beauty of the national syllabus is we won't have to keep retraining new staff as we employ them. We will be able to port it in if they've done the national training as well. And it starts from a real sort of understanding of patient safety at grassroots level, at practice level, that's aimed at staff right up to board, understanding what our patient safety is and our responsibilities. What is significantly different is the patient safety incident response framework, and that will replace the serious incident framework that we're all very familiar with now. And it moves away from that reactive and hard to define thresholds for serious incidents towards a proactive approach. And it promotes a range of proportionate safety management responses, which also include differing levels of investigation. They really focus on the quality of the investigation and the opportunities for learning, and the current timescales that are set in the serious incident framework. We've already been moving away from nationally during COVID to really focus on good learning. And they have very clear expectations about working with families, which we've started to do in this trust, but again, it's still a journey and we still need to work with that and their carers. And work with the staff involved in patient incidents, which we've already started, but it will be a continual journey in the trust. One of the other key underpinning elements of the strategy are patient safety partners. And we know we learn best when we involve the patients, their families and carers in their care. And from that, they have developed the role of patient safety partners, which are patients, carers and other lay people that can play in supporting and contributing in organisational development. And as part of that, they are suggesting actually using patients who have been involved themselves in safety incidents to provide that insight. That is still something we're exploring what that's going to look like in this trust. And the other element is the patient safety specialist, which I have already alluded to, who are recognised as key leaders. They haven't put in specific job descriptions and specific posts. What they want to do is add it to the most appropriate roles within organisations to develop real expertise, and they would do far more developed training and would be linked into more integrated patient safety across systems. At the moment, we initially chose to only identify one person, and that is our head of patient safety, because we felt it most closely aligned to that job description. But we know it's likely that we'll need more, but we felt until we got up and running, we just needed one person kind of understanding what it was we needed to do and to set a direction. You've got the slide with the requirements of the role. I'm not going to read it line by line, but can take questions or feedback if anybody has any thought. And I just want to talk about what we've been doing already to move towards this approach. So we've been moving towards it during the pandemic anyway, as instructed by NHS England. There was a directive came out to consider other investigative methodologies and also to really focus on learning, and that national timescales, the sort of set timescale for serious incidents were being flexed. Having said that, the serious incidents that did remain in the trust, we have internally tried to stick to those timescales as best we can. We've struggled during peaks of COVID, but we've tried to, because we didn't want things drifting. It's been really interesting learning in terms of the differing investigative methodologies. In some cases, we've managed to really support much more rapid learning, and an example of that was very early in the COVID pandemic, when we picked up really key learning about a particular pathway for children and escalated that immediately nationally, and changes were made very quickly. But other methodologies we know have led to broader in-depth learning that we haven't historically got from root cause analysis in an ambulance service. And we've had some quite long debates as to if it's something that's really picking up a broad theme across the trust, how we're actually going to tackle that. We're working nationally with areas. There were areas who were chosen as a pilot, and the pilot for the ambulance sites was LAS. So we've been working very closely with LAS to understand their learning. We already have a work stream for Just Culture, which Ali's team have led, but we're certainly a part of, because it's so integral to patient safety. We've already started, as part of the development of Datix Cloud, we've started to consider what we're going to have to weave in terms of the strategy, and that includes learning from deaths and how we're actually going to capture learning, what works well, because traditionally Datix systems are focused on incidents when things go wrong, and how we capture that learning and the themes. We've got ongoing development of the patient experience group, which we will believe will also be integral to the patient voice in embedding this strategy. We're currently completing a trust-wide assessment of where we are and where we need to go next. Looking at national learning requirements, in particular this national course, and how we would roll that out. And the development of a trust-wide delivery plan.
Judy, can I just interrupt you there briefly? I'm afraid in the spirit of safety, I need to evacuate the building because we have a fire alarm here at Crawley.
Oh, Lord!
To test the fire alarm, so I'm obliged to leave. So, Michael, if I can ask you just to continue chairing this section, please, and hopefully I'll be back by the time this item is concluded. So, but I have to do as I'm told and leave. So, Michael, I'll hand over to you, but Judith, please continue.
Thank you. I was a bit worried you were telling me I was taking too long because I was watching the clock.
Thank you.
So we're obviously, because it is a system-wide approach to safety, we are very integral to that. We're sort of members of the ICSs as they're developing the networks for patient safety. They are at kind of different levels locally, but Surrey are actually quite well developed, and that's built us a collaborative space to build relationships between the patient safety partners, which will certainly help with information sharing and collaborative working when we come to start to work on investigations together, and that trust. We know that Surrey Heartlands plans to adopt continuous improvement approaches to work fast and really challenge through rapid improvement tests, but we're not clear on how some of the other systems intend to approach it. But it also helps us to share the learning that I've already spoken about, and actually to develop our patient safety specialists. And in addition, in a way, we've got that additional benefit because obviously the National Ambulance Group, which focuses looking at patient safety and SIs at the moment, is also working together to look at how we implement the strategy within ambulance trusts. So there were a national ask of boards that needed to be identified by April 21. The first one was the identification of the patient safety specialist. That is complete, but obviously, as I've said, we think we'll need more roles. We've completed a number of them in terms of the providing the patient safety specialist name, the exec lead, who is the exec director of nursing. While I say there's further work needed to develop the relationship between the patient experience patient safety specialist and the NED with responsibility for patient safety, our patient safety specialist regularly presents at the quality committee. So there are links, but we just need to explore how we make them further. We've put it on the agenda for today as a discussion, so board members are aware of that role. We've got ongoing work looking at the work plan. It hasn't quite gone as quickly as we would have liked because of the pandemic, but it is ongoing. And in actual fact, we've already started unofficially some of the sort of work that would be included, particularly within the PSERF, by thematically reviewing and looking at RSIs already over the last couple of years. It is integral to the role of the patient safety specialist, but we do know that we will need more resource and expertise. But as I say, these are not about building additional posts. These are actually about using existing posts slightly differently and building on their roles. And also, it's really important these patient safety specialists are coached and mentored and developed. And we're fortunate in that we are joined onto the Surrey system because they've already started that work, because it's so system driven, the patient safety strategy, you can't do it in isolation.
Okay, Judith, can I comment?
Yeah, certainly.
Thank you very much for that. It was very clear and clearly a really important issue for the trust going forward. In a
Mind
moment,
if I put this off, Michael, so I can see people?
Yeah, certainly, no problem. Thank you. Thank you. Just before I open it up to questions, and I'll go first afterwards to Tom as chair of the Patient Safety Quality Committee. Can I ask you, Judith, what's the timeline? So this is something that is really important for the trust. There are a number of actions required of us. What do you envisage the timeline to get all of this stuff done? And, just would be grateful if you were as realistic as possible.
Yeah, the key next steps that I've just shown, I would expect to have in place by the end of March. But we know it's such a dramatic shift in terms of patient safety. Organisations are going to take a while to get it up and running. And you could be looking at, a good 2 years before we feel really comfortable in what we're doing and how we're embedding it. I would like to see movement within the first year, but we know that it's taking a while. And we know from some of the pilot sites that it took them a long time to get up and running. And even after the pilots, they were still having to work on elements. So it's not something that I'm expecting to say, we'll be done this in the next 6 months. It is going to take longer.
Okay, and then my other question I would have, do you know yet, I appreciate it's not new posts, but it is important that we invest the right amount of time and energy into this. And will you be in a position to at least quantify to say that broadly of our current workforce, however we define the roles, this is the level of broad time that we're going to have to invest in that? I only ask that from an accountability because I'm sure David and others will want to be confident that we are putting the right level of resource in, that we're not in any way skimping on this. I'm sure we wouldn't, but it is important from an assurance framework that we do know that.
Yeah, we're currently doing the gap analysis, as I've said, and working up the plan. And I think once we have that plan, I think we'll be clearer on the amount of resource. But I think at the minute we can't underestimate that we will need resource because it's such a shift in thinking. We're going to have to reach out and really work with people right at all levels right across the organisation to help them and understand it and engage them in it.
Okay, thank you very much. In terms of order, I was going to go to Tom and then I think Peter and then Chris, but I see that David Astley's returned, so I can hand back to you, David.
Can you just carry on to the end of the item, Michael? I think it'll be safer.
So Tom, I was just going to give you first opportunity. Yeah. I know you've been involved in this. So.
Yes, thank you. And I should say that it's very welcome to have this presentation here. Clearly we are on the way. There's a lot of work going on. It's not as if this is a blank sheet of paper for our organisation. I can see Judith and Tammy and the team have done quite a lot of preparatory work. One of the first things I did when I read this was contact Tam just to say we need to touch base about this new formal role that she's taking up and how we develop that relationship, because clearly we want to get it right. And one of the other questions that was in my head, and Michael, you've already raised it, was about resourcing, and obviously we can't answer that question now. And Judith, the gap analysis will be very useful to learn more about, because I think the nature of our organisation, how geographically spread we are on things, is whether one patient safety specialist is going to be adequate for what we need, but clearly the discussions about what we need are ongoing. I had one specific question, which is probably for Fiona, though. The medical examiner role that appears on one of the pillars, what are the implications for us in that?
So thank you, Tom. I believe this is more of a regional role, so the acutes have medical examiners. We don't have a medical examiner, but we are trying to link in with the acutes, because as you'll see from the Learning from Deaths report, we only look at the deaths that occur in our care. What we don't look at the moment is those deaths that occur in the emergency department or within 8 hours of a patient's arrival, and whether we had any influence on that. So I think this gives us the opportunity to work with the acutes much more closely. Yes,
the data sharing issue is really important for us in this, and I think Judith, earlier on you talked about pathways, and I used the example of STEMI, ST elevation myocardial infarction, where there can be harm because of delays and a whole range of other things. But how do we work across our pathways, across our system to keep people safe and to learn? The other thing I wondered about, some NHS organisations have introduced this concept of the greatix. So when something goes well, that's reported, and that becomes, so we flip our mindset to recognising what we do well, and I think that's a very welcome approach in this strategy.
Okay, thanks, Tom. Thank you very much. Could I go to Peter? I think you were first after that.
Yeah, it was just to clarify, Michael, that because I don't think it's explicit in the next steps, but the strategy, as I understand it, also includes an ambition for the quality and patient safety committees to include a patient safety partner by June, I think, this year. So I was just going to say that perhaps through QPS we can pick this up in the coming weeks about how we might achieve that.
Okay, that's fine. Thank you very much. Sibu, I think you had a question.
Yes, I did. Thank you, Michael, and thank you, Judith. This is really helpful and really good to see, really informative. I had two small questions, I hope. What you mentioned in there about other roles, and of course, Freedom to Speak Up does quite a lot in terms of early signalling about where there might be a patient safety concern. So I didn't see it explicitly involved there as part of this strategy, but are there plans to? And then the other aspect of this would be around co-production and co-design of services, because of course that would be a preemptive way of dealing with patient safety and involving patients at a very early stage. I know we had some thoughts around doing that, but how far are we in terms of moving that along?
Okay, my apologies. I think my camera's failed. Philip tells me you can't see me, so it's not me left the camera off. In terms of freedom to speak up, Subo, it's really important, because when you come to work up your patient safety incident response framework, you look at all your data. I'm not sure there's a role for the Freedom to Speak Up Guardian to become a patient safety specialist, because they do not have the right level of knowledge. But what you would be doing is, when you're looking at your themes and trends to set out your PSERF, as it's shortened to, you would absolutely be including data coming in from Freedom to Speak Up, and you would include your soft data as well as your hard, which can also be just as important when you put the picture together. I forgot what you said about the second question. Sorry, Subo.
That's all right. I was talking about co-production and co-design of services, because there's a preemptive aspect, isn't there, to patient safety, and that is involving them at a very early stage. So, and I know we had plans to do that, so I just wondered how far along we were with those.
We're not yet, but actually, when you look at the patient safety strategy, it's not just within one organisation. It's about looking at learning right across whole pathways. So we need to think about how we would involve them internally, but also systems will need to think about how they involve patients looking at pathways. Your perfect one, I think, for an ambulance service to start with, not just the semis, is your falls. Very often we're starting to look at patients that have waited a while for an ambulance, but actually I've been talking to the system for some time, but it's just nobody's been able to engage because of the pandemic, as actually almost doing retrospective investigations and looking at the pathway back and looking at where there are opportunities and working with the patients and their carers to understand, was there anything preemptive we could have put in at that stage so they didn't actually end up needing the ambulance service.
Okay, thank you, Judith. Thank you for that one. And then Chris, I believe you got a question.
Thank you, Michael. Thank you very much, Judith. It was really quite a good report. And what I just wanted to ask you, Judith, how do you think the just culture is going to impact on the quality of investigations? And
it's huge.
Yeah. So I mean, it would be really good to really see how we can be able to use that for future, because one of the things that I want to say that, you know, last year I was a judge on HSJ Awards for patient safety, and the LAS, they got an award. And one of the things that really impressed me in terms of that was that they listened to their patients. Now, the question is, how much engagement do we have in terms of listening to our patients, and how do we put that into our just culture framework?
Certainly, whenever we have our serious incidents, we try and involve patients, carers, families, and we try and involve the staff involved. But we know the culture in CCAM, some of the elements we come across is no different to the rest of the NHS, whereby people are scared to get involved because they think they're going to get into trouble. And the just culture really starts to break that down and just accept us all as human beings and making mistakes. And we know from some of the investigations that we're doing currently and the different methodologies, when we really engage staff and they really understand what we're trying to do, you get such phenomenal learning. We do early steps with patients in this trust. We are asked, are there any questions, or relatives, do they have any questions when we're doing investigations, and we keep in touch throughout investigations. But I think the involvement potentially of patients actually sitting around when we're actually investigating could potentially, or a family could enrich it as well. But obviously, you know, when something goes wrong, it's a very emotional time, and we need to bring that in very, very carefully if we're going to do that.
Okay, Judy, may I ask one final question from me? In another role that I do, I'm aware of the report that was published by Baroness Cumberledge about 18 months ago around patient safety, particularly in the area of medical devices, and her concern, one of the big concerns that the Baroness had was the lack of patient engagement and consultation in a whole range of issues. I'm interested in the concept of medical devices. Is that, and that's less of an issue for an emergency ambulance trust like we are in terms of use of medical devices and our patients' exposure to them, or is that an area that's growing really?
We've certainly had some incidents linked to life packs that have been followed up closely. And certainly there was a few linked to oxygen, but I am going to ask Fiona to kindly put her hand up. I was going to ask Fiona to feed more. You tend to see it less. I've seen it more in other areas linked to things like operating theatres and things like that.
Yeah. No, that's what I thought. But Fiona, please, I'm probably.
Thank you. So I would agree with Judith that this, firstly, isn't very high on our radar, but and probably should be. But because we have a relatively limited range of medical devices, it's not that much of an issue. However, I would point you to our decision to change the way in which we provide spinal immobilization, which essentially was around applying cervical spine collars to which is often really uncomfortable, particularly for frail or older patients. And we consulted with the spinal injuries group on that. So we did have patient involvement because that is a group which have particularly strong views on that particular element of their care.
Okay, thank you very much on that. Judith, thank you. Just to conclude, to say a really excellent presentation. Can I ask the final question of you? Have you got what you wanted from the board today? I know Tom, excellent chairmanship of patient safety, will be taking this forward. This will come back to the board, I'm sure, periodically. But is there anything more that you want from us today?
No, thanks. I think it really was just to kind of set it out to the board at this point that this is the journey we have been on and are still on.
Okay, thank you for that. Back to David. Thank you, David.
Thank you, Michael. Apologies for the interruption, but safety is paramount in the organisation, and I have to lead by example and evacuate with the rest of the staff. All are safe. That was a really good discussion. I did hear most of it, other than the 10 minutes I was outside. Just to emphasise from the board point of view, the just culture, the ability to speak up in the organisation, people to feel able to speak up without feeling a favour. That's something from the board I expect to be role modelled by board members, but also as a board, I think we need to ensure that our staff get that message very clearly, and we demonstrate that through all future actions. It's really important if we're going to continue the transformation of CCAM, which is underway. Many good things have happened here, but nevertheless we still need to promote that spirit of openness and just culture for the benefit of patients and our staff. So moving on now to another matter which Fiona is going to lead on, it's termed Operation Carp, which is the name given to a recent police investigation, which involves some former members of our staff. So Fiona, do you want to briefly introduce this? This is still a matter under some form of investigation in terms of an internal investigation. So there's a limit to what we can say, but it was important this was brought into the public domain and to assure the public as well as the board.
Indeed, thank you, Chairman. And Philip referred to this very briefly in the Chief Executive's report. So this investigation, we've currently got a serious incident investigation being undertaken by an external investigator. And as we haven't got the report yet, nor the recommendations, my report to the board today is more of an interim update. But just to give some context to this investigation, it concerns two ex-members of staff who were arrested on the 4th of August last year, subsequently pleaded guilty to the charge of distraction burglary and were given a custodial sentence on the 11th of January this year. The nature of the offence of distraction burglary essentially was identifying patients at the end of their life and stealing their end-of-life care drugs, purporting to be district nurses. Now, as you can imagine, this has been deeply offensive to our staff because it was targeting really vulnerable members of the public. I've listed the initial actions that we undertook following their arrest. But in fact, of the 2 members of staff, the critical care paramedic had been suspended pending an investigation at the end of March. That investigation had been completed and was awaiting a hearing for gross misconduct, but we had not been able to undertake that hearing because of the mental health of the member of staff. The other member of staff had been off sick and was not in the workplace at that time. However, clearly we had 2 really important areas of focus to see whether we could have identify any of these actions at an earlier phase. This was around the security of our controlled drugs and of inappropriate or excessive use of the computer, activity, our CAD. And what we have done, certainly in terms of access to the CAD, is to strengthen our policy around that so that members of staff are absolutely clear of what constitutes appropriate and inappropriate access to the computer-aided dispatch system. And we will be going on to look for additional resourcing so that we can undertake regular audits of that. In the terms of security of our controlled drugs, these offences occurred in the Thanet area where we have an Omnicell system, and that was actually of real advantage to us because although we have a way of ensuring the safety and security of our controlled drugs on all our sites, it's very much easier to undertake an audit at the Omnicell sites. And we did a look back to see whether either member of staff had an excessive use of the controlled drugs that they had access to. That did not show any excessive, they didn't show them to be outliers in any of the controlled drugs that they had access to. So the police investigation, I think it's worthwhile highlighting, was around the attempt to divert drugs. And we have found no evidence that our drugs were actually diverted. However, we do feel that there's more work to do on our wastage, CD wastage policy. And I've made reference to that around what's called the dupe process. That's the disposal of old pharmaceuticals. And we have a good process in place, but we think it could be enhanced. And so our chief pharmacist is about to trial a different system in Worthing, which will be rolled out across the trust in the event that that is successful. So I think that's all I wanted to say, but I'm happy to take any questions, Chair.
Thank you, Fiona. I mean, clearly this was a extremely serious matter and regrettable. Are there any questions of the board, particularly, are you satisfied as a board that the actions that were being prescribed, as are being detailed here, are you content with those follow-up actions? So in terms of questions, then Chris, I think we're first.
No, it was just a quick question, Chair. Thank you very much, Fiona, for that report, which is quite sad in many ways. I mean, you as the medical director, do you think we could have done more to detect some of these activities or some of these members of staff? I know do you think we should be doing like more regular audits?
So, Chris, we undertake regular audits of our CDs. I think there is more work we can do around random audits of the use of controlled drugs across all our sites, because we know from a previous case that if we find somebody is an outlier, that does need to be investigated. And that previous investigation did show that we had a member of staff who was accessing morphine illegally, and they subsequently left the organisation. So yes, I think that it essentially, people who divert drugs are generally pretty clever, and they wouldn't be able to do it if they weren't really determined. So it's our job, the job of my chief pharmacist and myself, to ensure that our systems are as tight as they can be. I think the upgrade to the Omnicell system and the introduction of the software of Omnicells across all our sites will make it easier to undertake those audits. The system that we have in our non-Omnicell sites is tight, but it relies on paper records, and therefore it is more time consuming to undertake those audits. It's not that you can't do it, it's just much more time consuming.
But I'm assuming, Fiona, the independent review will obviously will come back with recommendations regarding our whole approach in this area as well. I think that's important. And we're going back to the previous item around just culture. We need to make sure that everyone feels comfortable to have their say about this and make sure that we do learn as an organisation appropriate lessons if there are any to be learned. So Judith, then I think Tom, you may have a question as well.
Yeah, it's just to reassure you, Chris, in terms of the investigation, we've used a very experienced external investigator who actually has experience in safeguarding, and in particular has experience in a considerable number of serious case reviews, because what we've got here is similar to what you find in a serious case review. You know what happens at the end of the story, but you have to be able to use methodology that maps out what was known at each point in time, because it's very easy to put the jigsaw together now, but you have to take it step by step and put that jigsaw of information, and that will tell us if there was anything we could have done earlier, and signpost us in the right direction.
Thank you. Apologies, Tom, my mistake. It was Howard next, then Paul, and Philip. Howard.
Thank you. Yes. In terms of the learning on this, I was just a bit concerned that in the report there's no mention of what I would regard as a very important aspect of this case, and that is that these employees, who are both, as it's mentioned, individuals working primarily in Thanet, that they were actually living together. And the fact that it's not mentioned worries me as to whether you think that is irrelevant piece of information, because I don't think it is. I think it's a very material piece of information that's omitted. And as I say, from a learning point of view, where you've got that sort of conflict situation, and I might be wrong, but I seem to recall there was sort of countersigning going on of drug issues. That, you know, that's a very material sort of area of concern from a governance perspective. And, you know, well, these things happen, we know they happen, but where they happen and where, in this instance, they have access to controlled drugs, to me, it's a flag that needs to go, a red flag that needs to go up before anything's happened. The fact that you've got people working or living together to access this. So could you please sort of comment on that?
So I think it's a very reasonable question, Howard, and we are looking at our policy on staff who work together, work and live together. I think the way in which ambulance staff have worked historically is you tend to have a regular crewmate, and that can lead to its own problems, because there can be, you know, you can feel that you're so close to somebody that you're not in a position to challenge them. And actually, I think that's almost more relevant than the fact that that these two were a couple who lived together, because they were in different roles. They did not routinely work together, although they did undertake overtime shifts together. But their primary roles, one was a CCP, one was a student paramedic, so they had access to different drugs. So I think it is less of an issue, but I think it's very reasonable to flag that. And it's something that Ali is very aware of and that we are looking at in terms of potential changes to policy.
Yes, and I think if I make a good question, Howard, it's got a detailed answer from Fiona. I think I'd use that as illustration to people listening into this conversation that we are going to dig very deep to make sure we learn lessons from this particular very sorry episode. And I think that's important that people do take that point. Some final comments, Paul, and then Philip.
Yeah, thank you, Fiona. I was trying to wonder what levels of assurance or oversight we had in this area previously, audits or other things that must have gone on a routine basis, you know, to see if we can learn from how effective they were.
So our use of controlled drugs is audited on a daily and weekly basis. We report to the board any losses of controlled drugs. This was something that was flagged to the CQC back in 2016 and 2017, and they were reassured and in fact assured in their most recent visit in 2019 that our management of controlled medicines, and in fact medicines of all varieties, had improved significantly. Our OTLs undertake regular audits of CDs and other drugs. So I am assured that our current state of audit of controlled drugs is really strong.
Right, thank you.
Because what you've given some assurance about, Fiona, is the misappropriation of drugs was not the trust drugs. It sadly was the drugs in use by these poor patients who these two individuals had abused, and that's something which we know our systems work and that's been discovered. But this is an important point and one we need to check on in future. Absolutely, Chair. Although I would say that the critical care paramedic had been suspended. Yeah. And there was an ongoing investigation into the possible misappropriation of a controlled drug. Yeah, and our systems have flagged that up, which again is important. Which is why she was suspended. Yeah, absolutely. Thank you. Philip, final word.
Thank you, Chairman. That was the point. The last 2 points are the 2 points I was going to make. One that it was our staff who alerted us to this. And that's a good sign. The teams reporting odd behaviour in terms of other members of their teams is a healthy sign. The fact that immediate suspension, and then when we got further information, immediate removal from the workforce completely, were also good signs. And then finally. Fiona said at the beginning of her report, this has appalled and hurt a huge amount of our workforce. And so it's an odd thing for me to say, but in some ways I want to apologise to the rest of the workforce who every day go out doing the right thing and never abuse never abuse the trust that they are given by our patients on behalf of these two people who were just reprehensible. And I think I'll leave it there.
Yeah, no, I think appropriately said, Philip. As Fiona said, people with any kind of dependency, particularly drugs and alcohol, can degenerate into some pretty appalling behaviour, and we've seen that here. The important thing is, as an organisation, we learn from this. I think we've got policies in place for independent review to make sure we do learn lessons. I look forward to that being discussed at the Quality and Safety Committee in future, and clearly the Audit Committee as well will want to be satisfied regarding the policies regarding procurement and storing of drugs in due course. But can I just thank the executive and Fiona in particular for your openness in this case. I think it's important. We are seen to learn, but more importantly, we are open about these things and within the appropriate, without prejudicing other rights, but that we are appropriately open and we learn. So thank you indeed for that item. Now we move on to the final item before we probably take a lunch break, is the COVID vaccination and vaccination as a condition of deployment. I think Ali, you're going to lead on this important item, very contemporary item.
Yeah, thank you, Chair. So just before, hopefully the paper was really clear, and it is a fast-moving situation, so I'll update on key bits, I think, within the paper as part of briefing the board on this. I do want to say actually that at the outset we had a webinar last week on this, and one of the early things we said as an exec team is that this is a piece of legislation that we are required to implement as a trust, but we will do so with as much decency and professionalism and support and caring of our staff that we can. So I do want to say that at the outset, I think, actually, because it is naturally a very emotive situation, and there are a lot of quite difficult conversations, I think, going on. So I think we do need to recognise that. So where are we? Obviously, the legislation came into force on the 6th of January, and there's a 12-week grace period as part of the legislation, which means that in terms of the effectiveness of the legislation, the major part of it comes into force on the start of April. There are some stages before that, though, the key one being next Thursday, which is the 3rd of February. which is the first date by which people need, which is the date by which people need to have provided evidence of their first vaccination or that they are exempt. And naturally with these things, because it's been emergency legislation by the government, then effectively a lot of these processes are being set up as the situation evolves as well. So there are multiple streams of work within this, and the exemption process is one of those. It's a national process, it's not a trust process, but we're required to see the output of that with each individual member of staff who's asking to be considered as exempt. A couple of updates in terms of the numbers. So in the paper, one of the big things that's trusts have spent a lot of time on is really working out which roles are in scope. And for acute trusts and teaching trusts, big teaching trusts, it's a much more complicated exercise than for us. Luckily, it's not often it's that way around, but actually on this occasion it has been a slightly easier exercise for us to determine which roles are in scope or not. So, and we have done that piece of work together with our recognised unions. So we've had many hours together working on this, working through every single role in the trust, and we have 100% agreement on which roles are in scope and which ones are out of scope. In the paper, at that point, when I wrote the paper, we thought there were 2,900 individuals in scope and roles which were in scope. We've now got a clarified picture, which is it's 3,325. And we've been working through all of those roles, as well as now we've got agreement on the roles. We also have applied a list of all staff members to the roles to determine which actual individuals are affected by being in scope as well. Informal conversations, is that in the sense of those at the stage of the process we're at, have been taking place over the last few weeks with each individual to ascertain what their status is. And the easiest way to understand this is there are three major categories in scope roles. So the first is those staff whereby we know that they are unvaccinated. And within that, there are two subgroups of staff who are either going to be claiming exemption or who will be declining having a vaccine in due course. So that's the first group. The second group is staff who are where we have an incomplete vaccine record, in the sense that they've had one of the vaccines, either one vaccine, or they've had the Janssen vaccine, which actually counts as a complete course. So that's the second group. And the third group is staff where we're still to find out what their actual vaccination status is. Now, at the time we wrote the paper, we were in the hundreds in terms of working through the list of unknowns. We're now down to, in the group one that I mentioned around where we know the staff are unvaccinated, we can say that's 40 as at today. In terms of those staff whereby we know that they've had one vaccine, that's 41. And in terms of staff where we're still working to ascertain their status, we have 82 members of staff left where we're still working to understand that. And there are sort of like good reasons for this as well, where people have been on leave and those kinds of things, so sort of understandable reasons. But people are working really hard on getting to a position whereby we understand the status of every single member of staff. So a few other things then to add as well. I mentioned about the joint work that we've been doing with the unions. We now meet with the unions every other day to go through in terms of like bits of work that we need to do together. Last week was primarily around the scoping bit, which we've completed, and this week we've been working through more detailed implementation pieces as well. One of the critical bits of work that we've been doing, which goes back to the tone point that I made at the start, is that there are a range of documentation letters which are available as national templates now, which were only just sent to us a few days ago, which we've been working on with the unions to make sure that they're actually sent in, they actually cover things, as well as being technically correct, they also cover the kind of tone and supportive tone that we want in our communications with our staff as well. So we're agreeing that the content of those letters with the unions, we think that's the right thing to do. Excuse me. A few other things. We've also identified that we need additional support for this, so this come up on a number of other items this morning. And I have to say on this sort of publicly thank NHSE&I, who've sent us 2 individual members of staff, an experienced HR manager and another manager who's got senior education and other background to actually help us as part of the work as well. And we have the head of our COVID management team and Ian Jeffries from my team, all of whom are working on this pretty much full time at the moment. And in turn, there are always the 1001 priorities on the people space, I have to say, and this at the moment is priority number 1. So it's getting a lot of personal time on it as well. There are a couple of things, I think, other things that are important the board should be aware of. The first one is that we'll be shortly be freezing vacancies for staff who may have to be redeployed into some of those. It is worth saying that the national policy on this is really clear, which is that we're not under any obligation to create roles specifically for people who are potentially in the redeployment situation. The way it actually works from the 4th of February, I can say January, the 4th of February onwards, is that we are required to work with those staff who've declined to have the vaccine and see whether or not their job can be readjusted. You'll obviously understand that that's quite difficult if you're a frontline paramedic in terms of being able to adjust that role. So we're not anticipating there's going to be a lot happening in that space. And then we're required to understand whether or not we can redeploy someone to a non-patient facing role. And again, the obvious place for us as a trust is within the EOC 111. The issue there is that we will prioritise our staff for potential redeployment to those roles, but obviously other trusts are also asking us whether or not there are redeployment opportunities within our control centres as well. So it's a really interesting scene in the sense that everybody's working on this at the same time, and there are sort of major pieces of work going on in each trust within our area and across the whole of England. So in terms of freezing vacancies, we'll be doing those shortly. In terms of ones that can be appropriately seen as options for redeployment, but also for new roles, people start to see that we're now applying the conditions within the recruitment and advertising that we do for roles as well, to make it clear that where roles are in scope, that proof of having been vaccinated will be a condition of employment going forward. Just the last one to mention, sorry, it's a really full update, but there is quite a lot going on this. So the last point to mention on this is a sector-wide, in terms of ambulance sector-wide, inequalities impact assessment has been completed, and Asmina from our trust has been part of the group looking at that. It's been led by a senior manager at LAS, and we've been part of that process. So we considered the EIA this week with our unions and looked at that. And I think it's worth saying that there are some negative impacts identified within there which we're working through, but there are also the justification, I think, which is the reassurance point for the board, is that with an EIA you're required to work out whether or not there's a legal or other justifiable reason for a negative impact, and we were able to identify that in the fact that there's climate legislation dealing with this. So I'll stop there, Chair. I say it's a fairly full update, but it is a really important and high profile area of work at the moment. So.
Thank you. I think a full update is what's being required, and this is a really key subject and presents some risk to continuity of service. So it's important to get to board airtime. Philip, do you want to comment first, and bring in Howard?
Yes, I was going to make a point that both this and the last item, the car park item, has seen really good joint working with all our unions, which we're not always able to report at these boards, but there's really good work going on between both groups in terms of this work going on. So.
Thank you, duly noted. That's good to hear. Howard.
Thank you, Chair. Yeah, I just wanted, just to push back a bit on the categories 2 and in particular 3 that you identified, Ali. Obviously, I recognise you've done incredibly well in terms of bringing these numbers down, certainly since the issue of the report, which is great. But given the tight time frame that you've highlighted, the fact we've got sort of 82 we don't know and another 41, I wasn't quite sure the category 2s. there's quite a lot of people that we've got to sort out pretty quickly, and the fact that they're on holiday or on off sick doesn't seem to me a reasonable reason for us not to contact them to establish their vaccination status, because we're going to need to get them booked in for a vaccination, because we've only got until Thursday to do that. So really just sort of, we've got at risk here 120 people, frontline people who may not, because Thursday is, as you say, the key date. At that point, we will know whether we've got a major problem of 120 odd people who can't work on the front line or not. And that seems to me, given where we're at, a really important issue right at this moment.
Yeah,
Ali, please comment, and then Emma's next in line for a question. She may want to add some to this as well. So Ali.
Yeah, no, just to clarify that. So I fully agree with you. So just to add two other bits of information, I think. So firstly, we have contacted every single member of staff. So it's not, please don't take from what I said that we haven't been in contact with everybody. So that is clear. And again, all of the remaining staff are being written to. I've been written to again yesterday. So there's been multiple attempts at contact, and contact is in progress. Just divide the two groups in your mind. The 41 group that I spoke about are staff that we know about, we're in contact with, and we know they've got at least a first vaccine, so they are compliant with the 3rd of February deadline. That their issue is the 31st of March deadline, unless they've had the Janssen vaccine, in which case they're fully compliant already. So I don't think we need to be too concerned about that group at the moment. I think the 82, yes, I agree. We're still working on getting that down, and our target is to make sure we've got an answer for all of those staff by the end of this week. I will give you a bit of context, actually, is that every trust is trying to do this, and I think compared to where we've got to so far, I was talking to the opposite number at LAS yesterday, and they still have 400 in the unknown group. So in terms of, it is nationally a really brutal timescale, I think, actually, in terms of implementing this, which I think is part of the reason why it's generating even more emotion than it would do otherwise as well. So hopefully that's helpful in terms of showing something.
Thank you.
Yes. Emma?
Thank you. I was just also going to provide some assurance. We've been, for the last at least 4 or 5 weeks, if not longer, on a weekly basis, every operating unit, because let's be really frank, 99.9% of these people sit under me, and very clearly, I want to retain as many as possible, but we must adhere to the legislation. There is no grayness. This is very much a binary. You're either vaccinated or you're not, and then there are repercussions of decisions that individuals make. So we have now, for a number of weeks, we've been issuing on a weekly basis names of people. Everybody has been contacted. The seriousness of this is absolutely paramount, and as Ali said, it's #1 priority for his team. I can confirm it's #1 for mine as well. We've also identified, to support this, dedicated managers that were pulling out of their day job, who will oversee this VCOD piece from an operational point of view, because what we must have is consistency, and we must have some really clear water to allow everybody else to get on with the business as usual, but actually put some real focused attention around those who have chosen not to get vaccinated. In terms of how you talked about booking people in for vaccinations, just to really clarify, this is the responsibility of the individuals at this point. They have to be able to provide us with evidence, and non-provision of evidence, i.e. they're not providing us with evidence, means that they are in the non-vaccinated pool. So I can't, the emphasis that is going on, the support that is being offered, the webinar, I think, was really helpful because it clarified pieces, but I think this is absolutely the #1 show in town, and I do thank my teams to having got it down to 82, and we need to be clear, some of those 82 may stay as unknown, because if people are declining to inform us, they will remain in the unknown bucket, and then we will address that from next Friday onwards.
Thank you, Emma. Tom?
Yeah, thank you, David. And just to say to Ali, thank you very much for the way you're approaching this on behalf of our organisation. I think it's a really good paper. I have 2 questions. One is about volunteers, and I think something's just pinged up on the text box here as well at the same time. But volunteers who are patient-facing in our organisation are within scope. Is that correct? So they're included in the numbers you're reporting here?
Yeah, so the way to think of this is that no, they're not including the numbers we're putting before you. What we're doing is we're concentrating on our staff primarily. So the way to think of it is that if you're involved in the delivery of a regulated activity, then you're in scope. So clearly, and it doesn't matter what your status is really, whether it's you're employed by a trust, you work as bank worker, your agency, your contractor. If you're involved in provision of a regulated activity, you are in scope, and clearly volunteers who go out and work with patients clearly are in scope. So we've tried to prioritise this as well. I think it's important to say as well, because our number one risk from our point of view is our own permanent substantive staff, but we are working on all of the fronts at the same time. So, but yes, the answer is they're definitely in scope.
Okay, thank you.
Thank you indeed. Chris?
Thank you, Chair, and thank you, Ali. Just a couple of questions. The first one, I mean, I've been working with NHS England on BME hesitation on vaccine. And now, what numbers do we have from BME coming to 200 vaccinated? I mean, if we try to do that kind of subsection analysis. And the follow-on question is that now, given the fact that we have got only until next week, the 3rd of February, if somebody contracts COVID today or the next couple of days, that means they won't be eligible for their first vaccine. Now, what's going to happen to those people because they're going to miss the deadline on the 31st? Now, the period of grace is gone. How are you going to deal with those individuals?
Yeah, thanks, Chris. Two good questions. So firstly, on vaccine hesitancy, as well as the webinar we mentioned last week, which hopefully all board members will have watched by now, but if you haven't, then please do recommend that people watch it. Is that we are planning further webinars as well, or directing people to other resources as well. I think it's fair to say we do not have the infrastructure that is like very large trusts to have all the where there are national specialists on things. So where appropriate, we're going to direct staff to other sources of information on. There's a lot of interest in this subject at the moment. So every day there's always some event going on whereby you can attend it and find out more about it. So we're going to direct staff as appropriate. BAME staff as a portion of our numbers, of the numbers which are remaining, if you like, then it's actually a fairly small proportion. So I'll say a little bit more about that later on today, if that's okay, in terms of part two. Sorry, I've forgotten the second part of your question because there was a multi-part question. What was the other part of your question? Oh, no, yes, if you get COVID, what happens? Yeah, there is some flexibility within the guidance, is that if somebody gets COVID and can't get vaccinated by the 3rd, then there is provision to deal with that. So there are rules which apply to that. So.
Thank you. I think, Tom, is that a new hand or?
No, David.
Okay, thank you. Just to summarise then, I think from the board's point of view, I think first of all, we welcome the report. To echo Tom's words, we also endorse the approach which the executives have taken in dealing with our staff, in being very even-handed and trying to ensure that staff are dealt with compassion. What clearly for some people is clearly a matter of conscience, and they have deeply held beliefs. That being said, this is legislation. This is not something that's optional for the trust, but therefore we are having to implement this information. So we do recognise that. Can I just check, Ali, if anyone is redeployed, is willing to be redeployed into another job, and in some cases that might lead to a loss of income, are people being made sure they're being made aware of that, are they?
Yeah, so it's a good question. So yes, we've directed staff to the phase 2 guidance. It's absolutely clear in there that where people are redeployed to another job which is on a lower salary, for example, there's no pay protection arrangements that apply to that, because it's effectively a new role. It's not like a situation with organisational change, which is a trust-inspired change whereby pay protection applies for a certain period. This is a matter of legislation, and whether it doesn't really matter what we think about it, particularly in that sense. Actually, the rules are set all nationally on this, so and the national policy is very clear that pay protection and it shouldn't be seen as akin to organisational change.
Yeah, no, absolutely. Thank you for clarifying that. And also, I did listen to watch the Trust webinar, which I thought was very good, and I also commend the information you provided for women who are pregnant or expecting to be pregnant, and I think that's as clear as a matter of some concern for our staff as well regarding the vaccination. So again, the way that was explained, I thought was commendable. So thank you for that. So the board can only be obviously partially short at this point regarding we're sure by the actions the executive have taken. I think there's some very good actions here. In terms of the outcome, we're still clearly scoping that and understanding it, but certainly to lose that number of staff from the clinical front line as a patient-facing activity is a cause of some concern. And let's hope that by this time next week, people will have been persuaded by the arguments and that number has come down even more. So. And we look forward to further risk assessments. Quality Patient Safety Committee will clearly monitor this closely over the next few weeks, and it's a very live issue, which obviously I'll stay in touch with the Chief Executive over. Make sure we are dealing with this in the best way we can. So we're a few minutes behind time, but I think these have been important items we've had to discuss. So can I say now we take Philip? You want a final comment?
Yep. I would like to say just one thing to close off that that subject, and that is in case members of the groups in section 1, 2, or 3 are watching this. There is some feeling that some of our people are hanging on because because of all the gossip about the change of legislation, and they believe that is going to happen. I've been around in government for a long time. I've never seen the government change a piece of legislation before it's actually been enacted. I think it would be very unwise for people to believe that that is the case, and I'll leave it at that.
Yeah, that was said in the meeting at a recent chairs meeting. The message I received at a recent chairs meeting. So we note the reports and the actions that have been taken. So now time for a lunch break. I suggest we reconvene at 1:30, and we'll then press on then with the integrated performance report. So thank you all for your attention. We'll see you shortly. Important part of the meeting, the integrated performance report, which brings in the committee reports as well. So Philip, you're going to say a few words of introduction?
Yes, please, David. So we have been trying to decrease the size of the IPR, but this month we've got some new items, and that's created a few extra pages. So I apologise for that, but the new items are important that we report on, and I think I still think it's becoming increasingly useful, this document. I then talk in my introduction a bit about the way in which we are performing at the moment. But the one thing that's clear is that we need to keep looking, because there are things that when we are concentrating so hard on the operational outputs, there are things that might begin to fall through cracks. We need to avoid that happening without us noticing. So it's all right if we notice and we do a risk assessment and we say, yep, that falling through the cracks is less important than what we're focusing on. But that's very much what this document should be allowing people to do. That said, we've said this time that we again accept the biggest exception is performance. So I will start by handing over to Emma to talk about that.
Thank you very much, Philip. Thank you, Chair. So there are a number of exception reports in the IPR, but I will pick up on a couple of them, but want to start with some real positives, please. So first of all, would like to talk about our 111 service. I did mention it in the earlier part of the board, but I think it's very important that we note the successes and the high achievement of the outcomes from 111. We recognise that the performance at service level of call answering is still poor, and we've talked previously about the demand that we have been receiving. But all the way through this, it's been really good to see that the team have kept a focus on the outcomes. So what does that mean? What that means is that patients are getting appropriate outcomes and they're not being escalated because they can't deal with the calls. And what I mean by this is, if you look at the revalidation rate for the 111 to 999 calls, we are regularly above 95%. In fact, most often even above 97%. So what that means is those calls that are initially identified as suitable for an ambulance disposition, they are reviewed. Almost all of them are reviewed, and actually that results in a downgrading of those outcomes to often other dispositions, still appropriate for the clinical presentation, but what it doesn't mean is that we have excess volume or additional calls that aren't required to land in the 999 system coming through to us. So that's a really important thing for our 9 service. I think also our revalidation and our outcomes for the emergency department referrals are also low. Nationally, we are definitely in the higher performing groups in terms of these outcomes, and I think that's a really positive thing, because at a time, particularly during December and previous months, we know that systems were running at Opal 4, emergency departments very hot, and whole system flows were really challenged. It's really important that the patients get the right outcomes, they get assessed well, but they receive those outcomes in the right place. And actually, a lot of the time, the emergency department isn't the right place. Either reaching out to primary care or pharmacies or getting self-care advice is the right thing. So I want to start with that from a 111 point of view. I also would like to pick up call handling in EOC. Again, has been an improving picture. We know that there was additional monies provided to us at the start of Q3 to support additional recruitment of emergency medical advisors, our call handlers, and that has resulted in a distinct improvement in our call handling performance. And just to note, every month we get a national, almost like a national league table amongst ambulance services in England. And I can report that in December, our call handling 90th, for both of our call handling, we performed very well. And actually our call handling 90th centile, we ended up not only going up in the table from 5th to 4th, but we actually demonstrated an improvement in overall timing, whilst the English average deteriorated. That was a similar trend that was seen in our C1 performance in December, where whilst the national average increased, we actually showed a decrease, so an improving position for both our C1 mean and our C1 90th in the performance tables. So I think this is a really important message to hear, that we are maintaining and we are working hard to continue achieving improvements where we can, where we perform well, such as our C2. The board will know that we are a strong C2 performer, which for the majority, that's a large majority of our calls, usually approximately 60%. Again, in December, we remained 3rd out of 11. So a really strong position from that point of view. Our C3 also increased. Unfortunately, our C4 didn't, and we remain in the lower quartile of the table, which is an area that we are putting additional focus on. But just to give a bit of context, they are also quite small numbers as well. But I think it's a really positive position generally to start my update, Chair. I would like to pull out a few specific things, and they are within the exception report. So I will be brief, Chair, because I'm sure people have read it. But I would like to just pick up on a few things. So first of all, there's a piece around abstractions. I know, I'm sure Ali will pick up a bit on this later. Our abstractions, so that's where we have staff not undertaking frontline duties or undertaking call handling duties. That could be for a range of reasons, from annual leave to sickness to training. We're still running at very high levels of abstraction. Our annual leave, whilst we implement a policy over Christmas which decreases it to keep the service contained and safe, you come back into, prior to that and into January, we are still seeing high levels of abstraction for annual leave. People have a lot of annual leave. Obviously, COVID, they also got permission to carry additional hours over from the year before, which has meant that we have more hours in the bucket that we can spend. And people are tired, so they're enjoying taking their time off and making the most of it, spending obviously time over the festive period with family and friends. We're also, apart from particularly the weeks over Christmas where we had sort of retention bonus in place, we are still seeing that that overtime is not at the same rate that we saw at the beginning of last year. So it's about 8 to 9%, but we've seen it higher previously. So overall abstractions is still a challenge. I won't go back over COVID sickness, we've spoken about that, but we're still a few percentage above where we would want to be for what we call standard sickness, so non-COVID related. Some of that is long term because we have staff who are still awaiting appointments that have been postponed, and obviously a lot of support is being provided around them where we can use them for alternate duties to keep them busy, keeping people motivated and engaged. Absolutely, we do that. But just to note that sickness levels are high. We are still continuing with training. We do recognise that we have some statutory and mandatory requirements, and we have been delivering a day of essential clinical skills, which Ash, who was here earlier, has been overseeing with my operational leads to make sure we keep that going. It is at a lower level than we had planned at the beginning of the year, but we have been maintaining it and targeting those people who hadn't completed it earlier on in the year. So that was just a piece around abstractions. Two other points I'd like to raise, Chair, are job cycle time. We know job cycle time has been lengthening, and it is a challenge. I think we have been seeing a number of issues that contribute to this. Whilst we have challenged numbers of resources in proportion to demand, our vehicles are having to travel further because in order to respond to the highest category calls, which inevitably prolongs journey time. We know that hospital handovers have also been prolonged. So when you look at the whole job cycle time, that has been a contributing factor. Ever since the introduction of PPE, people are having to wear an awful lot more to prepare to go in, which has contributed. And we need to recognise us, excuse me, people are being asked to make decisions about trying to keep people at home or whether to refer in. And at times there have been reports of taking long to get hold of other healthcare professionals in terms of supporting some of that clinical decision making. So there are a number of things. We are absolutely looking at all of them and recognising that the importance of balancing resource and demand geographically, because if we can keep people more local, they'll travel less far and we will actually get more efficiencies and they will be a happier workforce as well. I think finally, one of the things I'd just like to pick up is that the lost hours at hospital have really been quite a challenge for us. I will put it into a little bit of context. Actually, the South East region is in a fortunate position as compared to neighbours, both close by, whether that be in Portsmouth or further afield, up towards the Nottingham West Midlands area. There are hospitals that are really struggling with handover times, but we have, without a doubt, have had our own challenges. And they haven't just been in a single acute. What we have often found is the impact of the single acute is a symptom of a much wider flow problem across the whole system. So whilst we work with partners to implement diverts where we can to try and ease pressure for a short term, there have been some ongoing problems that have taken days to improve. It's really only been in the last, I would say, week or so that we're beginning to see the pressure lift a little bit. And I believe that that is due to the fact that not only are we receiving a slightly lower demand, but system partners are reporting a similar position, which is allowing a little bit of decompression. And I believe some of those medically fit for discharge, which were in very high numbers across the South East region, are now slowly beginning to get out of hospital. But a lot of work. I would like to thank my local teams because the engagement between our local ops teams, we call them HALOs, which are Hospital Ambulance Liaison Officers, has been absolutely remarkable over the winter, particularly around sites where there have been substantial delays. Yesterday we did some work around our IT systems and we reactivated them to go everywhere again. They have very good relationships, very good lifetime relationships. So we're really able to use them in all circumstances, whether it's at surge because of hospital handovers or other times to be a conduit for information. So really would recognise that work that is going on. I think some of the hospital handover challenges will remain at particular sites for some time to come, noting that Brighton in particular is obviously in the middle of a very significant rebuild. And they're taking some additional actions that should go live in February, which may well help. But I think we need to recognise that each acute has its own challenges at this time, Chair. I think probably the last thing I would just like to note is the key components around welfare. By welfare and the metrics within the IPR, They're measures around meal breaks, when people have meal breaks, how many people have meal breaks, and late sign-offs. We maintain a low level of people not having breaks, so usually under 2%. I believe more recently it's dropped below that. But I do recognise that actually we are not achieving where I would like to be for people having a meal break, what we call it, in the right window. So what we try and do with any shift is allocate your meal break in the most appropriate time, so that you're not given it, for example, 10 minutes after you start, but it's given within a window somewhere around the middle of the shift. We work really hard to try and achieve that, but it's very dependent on day as to where vehicles are and how feasible it is at the time. It is slowly improving, and we're also improving the fact that we're getting people back to the dispatch desk. So both of those are improving trends over the last few weeks from early in the autumn. We still have late sign-off that is higher than I would like it to be. So again, something to work on, but that's linked to the piece around travelling distances and having resources in the right place. But overall, I think the welfare metrics are also an improving position as well. I think I'll stop at that point, Chair, if you're happy, and take questions.
Well, I think we can bring questions at the end, if we may. I'll hand over to David next, and then to Howard to do the actual performance committee report. Then we'll take questions in the round then about all the items. Thank you for the comprehensive report. Very encouraging as well. Thank you, Emma. David.
And I'll pick up from here just to paint a bit of a rounded picture, and just for those who are not in the performance committee, as a reminder, as an executive, we get together every week, and on 1 week we look at assurance around the performance improvement plan and scrutiny of performance and some of the metrics that Emma has talked about. And then the other week we look forward, where we would look at a 12-week operational look ahead, and we will also look at the longer term 22-23 planning in this case. One of the things that the board saw back in December, we had an extraordinary session to look at readiness for Christmas, and we talked about a number of measures that we had put in place, and we reviewed those at the performance committee. One of the things that was of topic was the return on investment on the Christmas bonus that we put in place to protect the hours. And what we saw was a bit of a dichotomy, where leading up to Christmas and in the weeks through Christmas and in the beginning of January, we saw a decrease in activity. So it's difficult to make a like-for-like comparison. However, we did note an increase in sickness over the period, where we peaked at around 400 or in excess of 400 COVID-related absences back into December. Early January is where we peaked. However, we saw a reduction of 30 to 40% on what we call the late shift absences. So the 48 hours before the shift absences reduced by 30 to 40%, and we think that is as a result of the bonus. The overall cost of the bonus is something I think I'm going to pick on part 2, if that's okay. But we are still completing the return on investment and making a decision around whether we saw any benefit, and if that's something we want to carry on into other periods as well. Obviously, Emma has already referred to the annual leave policy, which kicked in through the period, which helped us protect the hours, and operational performance was stronger than we've seen, and we did have some very good hours through some of the key days as we went into the plan. One of the things that we have been exploring in the performance meetings has been around our 22-23 preparedness, and our workforce plans continue to evolve, especially around the front line, where we have generated a number of scenarios to try and understand what is the relationship between the activity and the forecast that we will see, our current workforce position, and what is the pipeline supply of additional colleagues that we can bring into the trust to help us deliver against performance. And the one thing I'll just bring to the attention of the board is, if we did nothing different, we would need in excess of 3,000 whole-time equivalents, and we currently sit at around 2,400 whole-time equivalents. And this goes back to some of what we've talked about in the first part of this morning, which is the importance of better by design. If we continue doing what we do, we will not be able to bridge that gap, because that amount of workforce is just simply not there. And we've talked about the clinical strategy today as well. Our clinical strategy setup simply cannot cope with that pipeline growth in a single year. And we're trying to understand what is the whole system relationship between that activity and the forecast, and what we need to succeed. The plan where we are getting together, and the board will see further in March as part of the budget process and the integrated planning process, is that we would need to deliver a 12% operational performance efficiency to be able to deliver performance by next year. And that is a draft plan that we're working through, but it reflects the importance to have a focus on these operational efficiencies and some of the metrics that Emma has talked about, job cycle times, how we deliver better cure and treat to help us reduce the job cycle times is going to be fundamental as we go into not only next year, but the next 2, 3, 4, 5 years, which is all what we're trying to do through the improvement of the care delivery model as part of Better by Design. That will be it for performance. I will just draw attention to a couple of the new reports that we have, just for the benefit of the board this time. So we have introduced 5 new metrics that are fleet management related metrics that we have discussed at FIC. So just for noting, we are starting to report on RTCs per 10,000 miles as a safety metric, percentage of planned maintenance, which is a good indicator of how stable our planned maintenance is, because we have both planned and unplanned maintenance, but we should be hitting high percentages in the planned maintenance. We are reporting on percentage of vehicles which are older than target age, and this is quite high at the moment. We are sitting at about 41% of our fleet being higher than target age. This is something that will change, and we will see changing over the next couple of periods, because we are bringing additional fleet and we are retiring a number of the older vehicles as part of our vehicle replacement plan. So that was always going to be the case, but between now and June, we are delivering 65 new vehicles and a number, this is DCAs, and a number of additional SRBs, which are rapid response vehicles. We're also starting to look at metrics such as how often do we need to recover vehicles, and we currently need to recover vehicles every 45,000 miles. So that's the average or the mean miles in between failures for vehicles, which is, again, one of the key metrics that assures us that we are keeping our vehicles on the road and we're not removing resources because of either poor maintenance or other items. And finally, I just want to draw attention to the vehicles off-road, which is, again, a percentage that effectively tells us how many of our vehicles are not being able to be used for operational resources, and that's sitting just under 10% for our entire fleet, which is a good metric. It's better than it's been in a long time, because this is one that we have internally been reporting, but not at an IPR level, not at a board level. Finally, just if I may, we are also reporting on business intelligence and how quick we're able to respond to the needs of the business, because that is a key part of us becoming a responsive function to be able to make decisions. So measuring how quick we're able to pick up new data requests and close those is important. And also estate statutory compliance against low level water safety, fire safety, all of the things that assure us that we are keeping our estate safe and fit for purpose as well for the purposes of board. And I will finish there, Chair, if that's okay.
Danny, thank you. Very, very, very comprehensive. Just to say, I don't think we should be shy of talking about the cost of incentives, because it's in the FIC report anyway. It's in the public board, and we are a public body, and the public needs to see how we're spending their money anyway. So
absolutely,
I'll be very happy for that to be in part 1. And so is there a headline you want to share?
Yeah, I'm not going to be shy about it. It cost us about £800,000 to incentivize for the period, and that's the 30 to 40% reduction of the 48-hour absence window before a shift is what we saw. We haven't completed the robust return on investment. That's the piece we need to come back with, but those are the headlines for now.
Yeah, so the important thing is we're doing it. You're doing that, and that's very impressive. But also, in terms of £800,000 versus delays, hold-ups into the system, harm to patients. Let's make sure we do that in the round. I think that's it's a very vulnerable time of year, and the ambulance service, we're the only ones that answer the phone 24/7. You're a member of the public, and it's Christmas afternoon. We're there for you, as Emma has articulately put so well put before regarding our response times, and we're answering the phone quicker. We're there. So quite frankly, that's something we should be proud of. You need to be evaluated, of course. We don't want to waste money, but let's make that point as well. We're there for people when they need them, whereas other parts of the system currently aren't. So let's move on to Howard, in terms of the performance committee and the assurance process that we go through as a board around the whole issue of performance.
Thank you very much. Thanks, Chair. Yeah, so very briefly, we sort of scrutinised the information and data that Emma and David has gone through. So from an assurance process and approach point of view, we were assured regarding that. And from the integrated plan, we sought partial assurance. And I think that's mainly because it's sort of still work in progress. So some really, as we've been through already, some positive stuff on the performance cell and the improvements there. But obviously the new care delivery model design and so on and so forth, the timing is such that that's not going to really be ready for the 2023 sort of budgeting process. But suffice to say that it's in hand, but we can't get full assurance because it's work in progress. But it's really positive that it's happening, obviously. Some of the key limiting factors for next year are going to be, will remain, the ability to recruit and train, particularly newly qualified paramedics and ECSWs. So it's going to be about more effective use of those resources that are available. We were assured also on the 12-week look ahead, which now that we're looking back a little bit at that, was good. So we've seen, as Emma saw or mentioned, that there was some strong improvement on particularly in the call handling, 999 call handling. I note of late we've now achieved the targets for 10th of January, so that's great. And also continuing improving trend on 111 call handling. And also, although we are not achieving the ARP targets, the recent sort of trend is moving in the right direction. And as was also mentioned, and echo what Emma was saying, that the performance relative to the other ambulance trusts is good, despite the fact that we're still not achieving the targets, and hence we gave partial assurance to the overall performance. So partial because we're not achieving the targets, but we took some assurance because we're obviously doing well relatively. That was pretty much it from the performance side. Thank you.
Thank you very much indeed, Howard. Just to echo that point, really, in terms of we're not seeking to work to low standards, but we want to obviously keep striving for higher standard, meet the ARP standards, and make sure we can deliver on all our promises. But still, I'm pleased that you feel from the board, from the quality, from the performance committee, we have made progress in that area, which is, and the fact we're now also beginning to predict more our workload and take appropriate actions in advance. That's a big step forward for CCAM, and really commend the action that people are taking. So really, just in terms of questions, a lot in that, very important part of the meeting, how we're currently doing against what is a very difficult working environment, external to the trust. Members of the board, questions, comments, please, on all the matters we've heard about under this item. So I think Michael, you were first in.
Oh, thank you, Chair. Emma and David, really excellent. I'm really pleased by the quality of information coming forward. So well done. My questions, I suppose, are a bit of assurance, but more clarification. And I've got three. Emma, are you broadly confident now that, as best as we can, EOC staffing is more resilient going forward? The second question, or two questions, are probably for David. David, it's really interesting, and it's the first time we began to look at it in this way, so this is excellent. But you talk about a 12% efficiency. You talk about if we don't act and we continue as we are at the moment, we really have an unsustainable model over the next 12 months. So in terms of the board scrutiny going forward, what is the timeline? Because is it really that we've got a window of opportunity of the next 6 to 9 months to begin to make some of these changes? Because I'm just interested in our monitoring. There must be critical points in the next cycle where you and David and Philip and Emma need to say, we've got to this point, because if we haven't, we have an ongoing problem. And I think this is quite important David Hammond, I know, is not well at the moment, but that's quite important in our financial strategy in terms of the interaction that we have with the wider system. So that was my second question. I'm sorry, I've got three, but I'll give them all. My third question is, Emma, again, you comment on abstraction, and that, I really feel for you. That must be really difficult to manage. But it's the inevitability. Are we storing up a big problem for next year? Because, people have got to do their training. They've got to take their leave. And you know, with the best will in the world, I don't know how we manage this, to be honest with you, but I think we need to be aware that we've got, you know, an elephant in the room, if that's the right set of adjectives to use, that is going to be there for some time. So sorry, 3 questions. I thought I'd just get them out there. So
Emma, I'll start.
Border on point today, as you can see. So Emma first, then David.
So I'll answer all of them, but I think David will probably come back in for the second number 2 as well. I know you directed some of it at him. Number 1, EOC staffing resilience. Yes, I am more confident, particularly around call handlers. We still have some challenges around clinician staffing. We were given additional money to recruit clinicians, but it's a very challenging market because clinicians who can work both on the road, or in an emergency control room, can work in a GP surgery. A lot of them can work in other areas. So it's a very clinicians these days are a very marketable asset, which creates real challenge around opportunities to recruit. I know we've taken on some additional ones, and we've also been working with our paramedic practitioners out on the road to develop their skills so that they can also support and have a multifunctional role. So overall, yes, I do think our EOC staffing is in a more resilient place. I think, Michael, the challenge has been, and we have pushed this back to NHS England, and they have given us verbal assurance, but obviously the money that came through to increase the EOC staffing was winter monies to the end of March. Yeah. So we have done as we have been asked, which is to increase recruitment substantially. The challenge is now it needs to be followed by the budget as a recurrent basis into the next financial year. So I know that conversations are happening in all areas at all levels around this, not just us, it also links through to 111 monies as well. So there's a whole range here of when additional monies are put in for staff, not infrastructure, there is a recurrence that needs to be serviced by central government and NHSE. So that has been escalated, but I do believe we have a more resilient model. Okay, I will just touch on your second question, which is about the numbers, and I know David will come in on this. I think it's a really challenging position because what David said is completely right. But if we work down the Better by Design model and we are able to map a change, which means we deal with more virtually, it also means the split of requirements for staffing will look different, and that's the challenge we've got, because we need to plan the options going forward on the model we currently have and a model that we would like to implement, and they could look quite different. But that, so there's definitely more to come. But I'll stop that bit at that bit, and David will pick that up in a second. Last bit is abstractions. I think it's not just an elephant; it's probably a safari park in the room, if I'm really honest, Michael. The work that I'm doing, and I spoke about earlier, which was around all the training. I'm working with the team, so we stopped talking about abstraction as a single number, but we delineate it into separate pots. So we have a sickness and an annual leave, and a training one, for example. So we then set expectations for each of those metrics, and we measure each one separately against those metrics. So what we don't end up doing is robbing Peter to pay Paul, because training, unfortunately, is always the bucket that ends up losing when sickness goes up. And it does challenge us, because I do genuinely believe it leads to issues around retention, recruitment, as well as safety and clinical outcomes and all of that. And if we want to be an optimal service, what I need to be able to do is work with all of my colleagues and say, we will set sickness at 6%. Anything above that is in essence a cost pressure on that abstraction pot. But what I don't think we should be doing is allowing ourselves to move things around to try and keep it managed as a whole. I think we need to look at this more clearly and separately. And there are some really interesting things that have come out. We talked about long COVID previously. Anecdotally, we have more ladies who are on maternity at the moment or pregnant at the moment, and that's going to have a knock-on effect for a couple of years. So we have to do some of this planning in the longer term, because even small numbers of changes in different pots of abstraction can create issues. I think the last thing I'll just add, and it's something that's a bigger workforce challenge. We are working to really support people to come in and work with us flexibly. Flexibly often means not full-time, so that people have portfolio jobs. The challenge is every person who comes in still will need to undertake a training program, still will need to undertake all of those components. So proportionately, the costs, this, are more for a part-time person versus a full-time person. We still need to do that. We still need to make sure we have enough OTLs to support them. The challenge is how we square that off as we try and create opportunities that suit people better and work for us in terms of delivering the service. I hope that's answered those three from that point. I'm going to finish
clear.
with David.
Yeah, David.
Yeah, thank you. I'll just very briefly, because you've touched on all the points, that on the 12% efficiency, this is a good example of where a vision without execution is a hallucination. And we do need to challenge ourselves, because we can't just be asking people to, because effectively we're saying reduce job cycle times by 12%. We can't just ask our people to do everything they do, which is very complex and I don't understand and I'm not qualified to do. I can't say, let's do this quicker, team. That's going to backfire massively. So we need to think about it. We've talked about champions before and engagement, and how we bring some of these work streams together is how do we capture the ideas that make people's lives easier, make their lives more efficient? How do we tap into that method of continuous improvement that removes the things that don't add value to our patients from the process, so that people's lives are easier and they can deliver a quicker, better, more responsive care? That is not an easy thing to do. Now, we know what we need to do to balance it, and the 12% is based on what we think we can achieve based on where we sit nationally and where we sit across different OUs. So there's different OUs that achieve different things, but it is a big work stream that as an exec team, M&I and some of my colleagues have been discussing about how do we implement this, because it won't happen overnight and it is not easy and it's a huge gap. We will need to work very hard to make that happen by next year, but it is something that we need to make happen in due course and put those structures in place that help us deliver it in the right way. Otherwise, it's not going to be sustainable. We may achieve it for a month, but it's not going to be sustainable for a long period of time.
Okay, my only point is I really support what you're doing, and you're the executive team. I just think what you might want to think about in your business planning for the next financial year is just to be able to say, by this point in time, we hope, and I know it's a hope, because I think the important thing is these are not absolute deadlines, but it helps in terms of the scrutiny and assurance, and that's my only suggestion. But thank you, that's very clear.
Thank you, Joan. I'll try and rise to the challenge to make sure the board don't hallucinate. So very good. We note that. Chris Gond.
Thank you, Chair. It's just a quick question, Emma. I mean, I was looking at the annual leave and sickness. I don't know, do we have a policy where you'll be able to buy, annual leave back from people? I know some trusts are trying to address that. That's one way of they are trying to reduce the bucket full of annual leave.
Yes, so we're looking at that at the moment, actually, Chris. It's a really difficult challenge, because actually for the welfare of my team and the teams across the trust, people need breaks, which is why they get annual leave. But we do recognise, as I said before, people have brought extra leave over from last year. And actually some people might be happy to do so. So we are looking at it right now to see what could be done in the rest of this financial year. We'd probably limit it, because what we don't want people to do is sell it all off and have no leave, because again, it's really important. And recognising that COVID carryover rules were for a 2-year period, so that rolls into next year as well. But yes, we are looking at it at the moment, and aware that other colleagues in other services, they have implemented processes where you can buy back a proportion of whatever you've got left.
Yeah, it's been looked at. It's not a binding commitment, so there's still some work to do yet. So on that subject, thank you, Paul.
Hello there. Yeah, so I got well done, by the way, and a great report, and also a great performance over the last quarter, because it has been better than we anticipated when looking at the 3-month plan. So I've got 3 questions. One was around, we have an excellent performance, but looking at the fact that we were massively under-resourced throughout the whole period, it's difficult to see that in the dashboard, to be honest. When you get the headline figures about all the categories, you don't actually see the fact that we were 20% under-resourced or whatever. So I just wondered if there was a way of making that more apparent. You really have to dig through the report to actually, unless Philip kindly mentions it in his report, it's sort of hidden. And it's quite an important point, I think, that one. The second one is about the wonderful job 111 were doing about not sending ambulances out when it's not fully, it's not 100% required. They're doing a great job, but when you go out into the field, that isn't always reflected in what people say. So I just wondered if there's anything we could do to actually raise awareness about what a great job they're doing, because it probably hasn't filtered through the whole trust yet. And the last question really is that I think we've seen quite a rise in violent and aggressive incidents The last in December it was higher than ever, and double what it was the previous month. So I just wondered if there was something going on there. Sorry about the 3 questions. There's all at once. Right.
That's fine. I'm sure we can take away your request to see if there's anything we can do to make the resource versus demand stroke activity a little bit clearer, and probably we'll pick it up outside the meeting just so we can understand the detail. I know David's got some thinking about the IPR, so there might be something that we can do there.
Let's leave that a good. Let's note.
Yep.
Move. We'll bring that.
I think your 111 piece, Paul, is really fair. I think it's really challenging because I've been a paramedic a long time. I spent a number of years on the road when 111 came in, and there are certain myths that are very, very difficult to shake off. In terms of what 111 does, we do talk about, people don't understand quite the volume of calls that they deal with every day, and the fact that as much as 8 to 9% come to 999. Fundamentally, that means that over 90% doesn't come anywhere near us. So I think you're right. We probably do need to think about how we can do a bit more of that through the various routes. What I'm trying to do is also, as things are beginning to lift a little bit, we're also, when we talk about those portfolios, we're trying to get more of our our operational team leaders and our dispatchers to work more closely together, which I'm trying to get them into our control room a bit more. We've got clinicians who are actually interested in having part contracts and a foot in both camps. So that's that we're trying to encourage that. And really encouragingly, actually, I went to an end of NQP transition to practice program. I think it was in November, and there was an ex-EMA who's just finished as an NQP, and her colleagues, there was about 25 of them on the program, reported how beneficial it was because she could, as much as she'd been in an EMA, she also understood 111, and she was able to really give some of that from a personal point of view. And I think when you do it from a personal point of view, it makes it a lot more real. So some really fair points. The violence and aggression, I will just mention, and you will know this, and I'm going to ask Judith, she might want to step in. We're still doing the body-worn video trial. That was something that was started about 9 months ago. It's due to finish at the end of the financial year. This is part of a national program across all ambulance services to trial it. We will hopefully get some interim outcomes at some point in the next couple of months from our personal experience, but we're obviously feeding into a formal national evaluation that will take longer to come out. But that, I just wanted to note that was still ongoing. Judith might be in a better place to answer some of those questions.
Thank you.
About
Thank you, Judith. Quickly move on to Philip for some brief final comments, then we must move on because of time. But Judith?
Yeah, I think whilst I'm not minimalising the violence and aggression, we take it really seriously. When you look at the data compared to the number of incidents we actually attend as an ambulance service, we have to keep it in proportion. It is still a very small number, but that doesn't mean to say we don't take it seriously. So a lot of the work we've been doing is with the police to support them and work with them to take a zero tolerance approach to emergency service workers. The body-worn cameras, it is early days and they're still being evaluated, but there is some very early signs that they work in reducing violence and aggression. But also we know the Trust has been looking at conflict resolution for our staff to help them more able, because our staff go into some pretty awful situations where tensions are really high when they're walking in, and we know that we're looking for some of the training next year. I know Ash is looking at conflict resolution there to give them some more skills to manage that.
Thank you.
Thank you, Judith. Some good points there. Thank you. Philip, final word?
I think it's been said, and in view of the time, I'll let it go.
Okay. Well, just in terms of just bringing that to a very important part of the section, why it's important discussion ran on a little bit for that section. I think first of all, the 111 situation is much improved than where we've been over recent years. So can we just through you, Philip, make sure our thanks are, particularly through you, Emma, our thoughts are communicated to the staff. Our thanks for the work they've done and the way and their leadership for gripping what is clearly a very challenging situation. There's clearly some financial resilience and risks to be managed going forward around, particularly as you get into the contracting situation. I know the Finance Committee will have that clearly in their purview going forward to ensure that we get paid for what we do. And this whole issue around abstractions, I mean, the board have really set a very clear policy. We do want to make sure our staff are trained and developed. On this last issue around conflict resolution, for instance, there's some things you just can't do online. You've got to get people into a classroom and they've got to work with their colleagues on what's the best solution. So we've got to find a solution to that. Even if it's compromising in some other areas, we must prioritise and find a way through to get our staff the training and development they need. We're asking a lot of them, and we've got to make sure we give all our staff that opportunity. So that's something we will keep closely in the board's eye. So let's move on now to quality and patient safety. I think Fiona and then Judith are going to just introduce this subject. Fiona?
Yes, thank you, Chair. Good afternoon, everybody. Following Emma's lead, I will highlight a couple of areas of good practice before I go on to the exception reports. Firstly, our NHS Pathways Audit team, and those of you who've been around a while will remember that that has been a problematic area in the past. It is now stable, it is fully recruited to, and at times when the control room is very busy, they come off the audits to undertake call taking as well. And despite providing over 2,000 hours of call taking over December, they managed to achieve 96% of the audits, which is excellent. And secondly, our stroke care bundle has now been consistently above 97% for the last 3 months, which is a real positive. Moving on to the exception reports, there are 3 areas I'd like to highlight. The first is of relevance, considering our earlier discussions around Omnicells and controlled drugs. And this is around the single sign-outs at Omnicell sites. That is when one member of staff only signs out their drugs, rather than having it countersigned by a second member of staff. The numbers jumped up in December. Normally, that's less than 10 across the trust in a month. But for the last 2 months, it's been over 10, and in December, it was 23. We believe the reason for that is that for each of those single sign-outs, an OTL has to validate the reason to see whether it was a reasonable reason. There was nobody else around on station who could possibly countersign. And during December and indeed November, OTLs were very involved in providing frontline services, and the numbers returning were lower than normal. So I think that was a falsely high number, and I would expect it to go down. There is no evidence that we have had any missing CDs over December. Secondly, the care bundle for STEMIs. Again, this is an ongoing issue. The figures have dropped down to 57%, which is poor. We're undertaking a deep dive, looking again at the reasons why we don't score on the STEMI care bundle, and looking again at how other trusts are managing this to make sure that we are actually comparing apples with apples. And then finally, under clinical education, there was an exception report around students at risk of not qualifying. This is the TAAP course at Crawley College. So we believe that that is in fact improving. In fact, the numbers would suggest that it's improving over recent months. We've now got much better regular communication with Crawley College, with regular meetings between senior staff. We've got an increased number of individuals undertaking the marking of submissions, and at each OU an OTL has been assigned to mentor or keep an eye on the TAAB students. So going forward, I think this burden will reduce. We also haven't got any new TAAP starting until I think the spring, so there's an opportunity to do some catch up there. So that's it from me. Thank you, Chair. So I'll pass on to Judith.
Thank you, Judith.
Thank you. 2 of the areas I was going to cover have already been covered, so I won't cover them, but I will start with a performance highlight in that duty of candour did improve in December. It continues to be monitored weekly. Just to give some context, duty of candour in an ambulance service, because of the information we have on patients, can be quite problematic. It's not a hospital where somebody's come in and been admitted sort of thoroughly and asked for next of kin. Very often when ours is late, it's because we're still trying to find the next of kin. What I can assure you is on the occasions when it has been missed in the past, they have all had duty of candour. It's just they may have missed the official timescale because we've been making strenuous attempts to either find the patient who's gone into hospital and moved somewhere else, or to contact their relatives. There's 3 highlights, 3 exceptions I just want to pick out. Complaints response times have been dropping. That is not because of us not taking it seriously. It's because whenever we reach a peak and activity is affected, we get more complaints. So that makes it more difficult for us to keep up with demand. Generally, most of the complaints we do respond within timescales. It's just per month you're looking at still relatively small numbers of complaints. So 1 or 2 missed deadlines can impact quite a lot. And they're generally the ones where they're the more complex complaints, and we're trying to liaise with operational staff to get the information we need. But as we've already highlighted today, very often the operational staff we're trying to speak to are out giving care to patients. The second exception I just want to put some, actually there's 4, focus around is the hand hygiene. And I just want to explain it. I would naturally expect hand hygiene performance to fluctuate. What I don't want to see is a steady line at 95%, because that would tell me our audits aren't rigorous. But nevertheless, it is lower than I want it. We have a plan to improve that, but some of the data is also being impacted on, again, by operational colleagues being really busy. We know some areas have managed to do less audits than usual, so that affects it. And it's not an area I can send the infection control team out or myself to go and do, because you get the Hawthorne effect. We stand there somewhere near a sink or somewhere near our crews. We know we're watching and their behaviour changes. So it has to be kind of operational colleagues doing this. The safeguarding, just to highlight the reduction in level 2 training, I just want to pull out that doesn't mean to say staff have not been trained. We've focused this year on level 2 training for new staff, but we're going through the three-yearly cycle of level 3 for the clinical staff. So a lot of people that it looks like they haven't had level 2 will have had level 3 this year, but obviously we'll look end of year where we're at, and there will be more focus next year on level 2. And finally, I said 3, but there are 4 exceptions. The 4th is the SI actions that appear to be delayed. Just to be really clear, this is where we do not have evidence they haven't been implemented. It does not mean that there's that many serious incident recommendations have not been learnt from and embedded. We're still trying to gather the information. We don't think the way it's reflected on the IPR is helpful, because it doesn't reflect percentages. So the percentage we know is improving, but the numbers don't seem to. So I've asked the team to look at a better way of representing what we're doing. In the meantime, we're really working to support the governance groups, and the team are going out to the governance groups and who should be monitoring their own actions. And the feedback I'm getting is when the team actually go through and talk the governance groups through them, they're finding that really helpful. And what the team are finding is very often the work is happening. It's just nothing's been fed back to us.
Thank you, Judith. Tom, would you like to give the report from QPS? Then we'll, the Quality Patient Safety Committee, then we'll take questions.
Thank you, Chairman, and thank you, Judith and Fiona. I will just scroll to the document here. So we only met last week for QPS, and some of the issues that we discussed have actually just been covered by Judith. Sorry, I'm just scrolling. We received some management reports on duty of candour, and Judith has addressed duty of candour. What we've asked for is we recognise and we are assured around the focus that actually the numbers are relatively small. So we report in percentages, but then the absolute numbers are actually quite small. We're assured there's the right level of focus, but what we probably needed was more information in due course back to committee about how we're preparing our managers to have what can be very difficult conversations with families when things go wrong, because we want to look after our managers who are having those conversations. We had an update on our 111 electronic prescribing service, which is a relatively new and I would say jewel in the crown. It's a really important offer for our communities that we serve. So just about 6 months in, things seem to be going very well. The preliminary data we looked at did suggest that we need to do a bit more exploring of variation in prescribing rates, to have a focus on our responsibilities around antimicrobial stewardship, which is really around antibiotics. Antibiotics seem to be the most frequently prescribed medicines through our service, and we just want to make sure that we're on the right track with that. So we've asked for a further report in around 6 months, just to help with the assurance on that. But overall, we were assured that service is safe and it's coming along very well. We had some scrutiny items, infection prevention and control, which I think is covered. We've had other discussions about it today, but it does seem hand hygiene is something that we really need to get a renewed focus on. And we did see data on not just respiratory illnesses, but tummy bugs, to use the technical term, that probably if we had a renewed focus on hand hygiene, we might see a reduction in sickness absence due to that, protect our staff, protect our patients. There is an action plan on this, which we've asked for a report back on in a few months' time to make sure, again, that is on the right track. We had assurance and a very good conversation around the use of volunteers for responding to suspected cardiac arrest using the Good SAM app. So we were assured that the governance around that is correct and safe. And the chairman actually did make a point about how we should really find a way of thanking those who step up to go and help in their neighbourhood when we ask them to respond to a cardiac arrest, and that we subsequently look after them, because these can be very challenging circumstances. We received partial assurance on the recently introduced approach to mental health safety in the EOC, and quite a few of the issues that we were discussing were very complex technical things around the IT, but overall we felt that as an organisation we have much better oversight about how we're looking after these patients than we had hitherto. We have asked, though, for a further update in around 6 months' time once this way of working has fully embedded. We had a superb report on the Trust's research and development activity. This was a response to a query from one of our previous NED colleagues around the impact. Can we demonstrate the impact of the research? And the answer is that actually these really high quality, multi-centre, nationally funded trials take years to do. So the benefits realisation, if you like, may be some way off, but actually fulfilling our responsibilities to engage in the research endeavour as an ambulance trust, we were able to commend them on. There was also a specific point about the R&D team in our colleagues in R&D who aren't funded to do this, but they've been extremely helpful during the pandemic in undertaking rapid literature reviews to inform decision making around what we do. So we thank them for that. We received a number of annual reports which are on the agenda for this meeting today, so I won't go through them. And then we had an alert from Fiona just to inform us on the safety front around some changes to what happens in mid-Sussex when children have a cardiac arrest and which hospital they go to because of the facilities and staffing situation in the acute trusts. And I recognise, and we did document it in this exceptional report, Fiona wasn't necessarily expressed some concerns about that change in practice and sought advice and guidance from NHS England, and the medical director for NHS England in our region has confirmed that children who have a cardiac arrest in mid-Sussex will no longer go to the Princess Royal Hospital, but will go to Brighton or to a hospital in the other direction. So that carries all sorts of implications for us, but it's a system risk, as Judith has assured me, and the board just need to be aware of that. And operational instructions have been published, so our staff are aware of it. The numbers are very low, but these are children, and this is a very difficult, challenging, emotional circumstance to have to deal with a child and with a family in these circumstances. So the board just need to be aware that at QPS we were alerted to this issue, and the NHS England have confirmed that's what they want us to do. I think, Fiona, is that a fair representation of that last issue?
Absolutely, Tom. It's absolutely fair, and we have subsequently raised it with the Doctor for Child Deaths in Sussex, who has confirmed that he feels that the existing arrangements are adequate.
Thank you.
Okay, thank you for that clarification. Right, colleagues, questions on matters of patient safety? So comprehensive reports there. Any questions the board wish to ask? Chris?
Thank you, Chair. I mean, it's a quick one, really, because I know the LAS have published some data indicating that they've found if you are a BME member of ambulance services, you are likely to get more attacks. Now, if we witnessed that at SICAM?
I think maybe either Emma or Ali or Judith, have you got knowledge of our statistics?
Yeah, because obviously the attacks get reported on the DATEX system, Chris, and we're doing some work we've started off first of all with people who complain, collecting special characteristics, but we know we need to start to really focus as we're revising our DATEX system. We're moving to a cloud-based version to start to collect that data, but it will need work with investigators for incidents and the staff to understand why we're asking that question, which is why we haven't just suddenly added a field.
Okay, but one we are becoming increasingly aware of, and so we will do some sensitive work with the appropriate colleagues to bring that
Absolutely.
forward. So, thank you, Judith, for that answer. Thank you. Are we therefore? I take with absence of hands that people are content with the very comprehensive reports we've had about patient safety, and I think we've also highlighted areas where we do need to see some improvement. But overall, there's very positive information there. But we're being also open about areas of I don't think anything's left uncovered there in terms of actions going forward. Okay, thank you for all that. Let's move on now to workforce, and I think Ali, you're going to introduce this item.
Yeah, thank you, Chair. Thank you, Chair. Yeah, a couple of things I think to sort of pull out. The first one was sickness. It's already been covered several times during the meeting, so I'll cover the 2 or 3 points that haven't been mentioned so far. So the first one is in the exceptional report. We talk about the sickness action plan. This is a 23-point plan which we've developed and is jointly being implemented between Ops and HR. The report makes mention of revised guidance being required nationally, and the precise issue here is that the guidance on COVID sick pay and the way we manage staff who are affected by COVID is different to all other staff, and it's been flagged multiple times by myself, Chief Exec, and others on national forums, etc. There's no sign of it changing yet, but my understanding is that situation may change over time, over the next couple of months. So, but in the meantime, we have to work with the national rules as they stand. So, but it does make a difference. But so the other point that Emma covered in great detail was the issue on abstraction. So, I just wanted to leave the message on this one, which is the 3 big areas of concern around sickness are around COVID, mental health, and musculoskeletal. So unsurprisingly, they tend to be, the 2 of those 3 are always in the major cause of absence, but they're all part of our action plan in terms of dealing with them. And the senior management group of the trust, which is the group that reports through to executive management board, monitors and manages the plan on a weekly basis. So there's a lot of work going on, I think, actually with this, and we've had a lot of this detail back to WWC as well. The other one just to touch on is on turnover, and I do want to draw a slight link between the 2 points here and also one other thing that's been covered. So turnover rates continue to be higher than they have been in the past, and the report makes mention of the simply due to the fact of burnout and pressure on staff, I think, actually. So The three most common reasons for people leaving the organisation are work-life balance, health and well-being, and hours of work. Now, Emma's touched on the hours of work point and the kind of things that we're working on around meal breaks and late finishes. So I think they are clearly key features in terms of in people's minds when they're making a decision to leave. So I think that as we're focusing on those, and it's good to see the numbers coming down, I think that's an area we need to keep working on. The work-life balance one, I think somebody asked the question earlier about, should we look at buying out annual leaves, and this actually really is a genuinely double-edged sword, I think, for the reasons we'll discuss, which is, yes, we can buy out annual leave, and we could do it, okay, and we are looking at it, but actually it does have the counter effect of actually reducing downtime for staff. So I think as part of the health and wellbeing strategy going forward, I think we will need to think about this in a round, I think, rather than just as a singular issue, which is to buy out if you like, a problem that may be, I think, carrying on for the next 12, 24 months, actually, in terms of the storage of annual leave. So I still think that's going to be an issue. And the other part of dealing with the work-life balance issue is we are currently looking at an agile working policy for the trust. It hasn't had one before. It's had a flexible working policy. It hasn't had an agile working policy. And we do know from, for example, with the hundreds of staff who are still working remotely, that a lot of staff would like us very much to actually think about how we can keep that a more hybrid pattern going in the future, and a lot of remote working. So that's a piece of work that's also aimed at addressing some of that. The last point, just on, on health and well-being, as a turnover reason, our wellbeing hub, which actually has been really, really valuable, I think, over the last 6, 12, 24 months, and really highly used by staff and managers, continues to be fully occupied. We've also been provided extra support by NHS-EI, again, just to call that out, because I think actually that's been helpful in terms of additional welfare funding. I think nationally, as part of the people plan and the people promise, a lot of money and effort is going into health and wellbeing. I think the problem with this, I think, actually, is that often it's non-recurring monies, and what that means is you have a sort of a stop-start effect, and I think therefore one of the things I think we could do as a board and as individuals on the board, I think, is continue to make the point, and I have done personally to higher powers, as it were, that where they give us money to do things like this, that we should really aim to have recurring funds and investment in health and wellbeing, not something that's just going to be a few months because there's some funding left at the end of the financial year or something like that. So. And the last one to mention on turnover is we've got a health and wellbeing board now established. It's been running for some months, which on behalf of the board, Tom and I both go have the pleasure of chairing that, and we've done quite a lot of work on that so far. Tom, you might want to add on this as well, but we've been looking at the effectiveness of the wellbeing services that we offer already in terms of value for money and how they're used. We're also re-procuring our occupational health service as well, and we'll be looking at a new refreshed health and wellbeing strategy going forward as well. So we're directly working on the top 3 causes of turnover, I think, in terms of assurance to the board.
Thanks, Ali. Tom, as welfare guardian, is there anything you wish to add to that?
Yes, just to reiterate Ali's point about the programme board, there's an enormous amount of work going on behind the scenes. And our well-being offer as an employer, as colleagues, is actually substantial, and the value for money work, which I won't preempt any formal report that comes here at a future meeting, but is very encouraging, and it's good to have an independent look at these things to make sure we're spending our taxpayers' money well. But I think there is something about how do we, with all these other pots that Ali's talking about, these monies that come in dribs and drabs, how we get them into our baseline, I think is a really good point that we probably need to explore, going forward. But I think they're doing a cracking job, Ali. Thank you.
Before I bring in Subo, just one point I want to clarify for the benefits of the board. People with COVID, members of staff with COVID, have currently unlimited sickness benefits. Is that? Do I understand you correctly?
Yeah, so currently the rules are that for anybody else, for any other source of absence and sickness, sick pay entitlement expires at a year. It's 6 months full pay, 6 months half pay. With COVID, It's full pay throughout. So, and it's not whether it's the rights or wrongs of it. I think it's actually in practice it's quite a difficult thing to actually manage. And so what it means in practice is you're working on a welfare-based approach with staff, which is fine, I guess, actually. But I think we're at the point now whereby somebody with, I think Philip mentioned the point earlier, if you take a comparator of a member of staff who's contracted cancer, for example, or another serious disease, then it's sort of how you manage the two. I think it is sort of at that kind of point now because it's been going on for so long. So they're the kinds of sort of like really tricky issues, I think.
Well, I'm glad you flagged that up. I think it's one that I'm sure the Workforce Committee will keep under review in terms of the risk register and also the sympathetic handling of what can be quite difficult cases to manage. So we come in with the basis of sympathy, but it could well be a challenge going forward. So Subo, would you like to bring out the highlights from the escalation report?
Thank you, Chair. And everyone has stolen my thunder, so this is going to be a very quick sort of pulling out of a few key points. I'm standing in for Laurie, Chair of WWC. So just to say that executive escalation, we've already covered VCOD. We also looked at the completion rate for appraisals. We had some concern about the very low rate of completion, but for all the reasons we've already discussed in the board, there will be some ongoing challenges, but we'll keep an eye on that. Moving to the items for partial assurance, we've already talked a little bit about recruitment. We've already talked about health and well-being, and Thomas filled in there about the value for money exercise, so I won't go into that. Ali has already talked about the sickness action plan, so I won't go into that. Just to say on learning and development, it is a constant conundrum on WWC between abstractions and training. I think we talk about it at every meeting and how to get the balance right and how to get the balance of risk in the right place as well. But I'll echo what Emma has said earlier. Between her work and with Yvette working together, they're doing a fantastic piece of work, really looking at the overarching learning and development and the whole training plan that's coming together, which is really good. I think in there somewhere will be the skills mix and how that work relates to Better by Design. So I think we will continue to keep our eye on that. Also, just to say the violence and aggression, again, we have talked about that, but we have also said that we don't feel that the evidence is there yet showing us that it has a positive impact in terms of aggression towards staff, but we want to see the proper evaluation and the cost and benefits of that. So that will come to WWC and we will look at that in more detail. As far as FTSE is concerned, we asked for that to come specifically to WWC because we wanted to have some sort of delineation between what were HR issues and what were issues around patient safety. We had some assurance on that there is more distinction between the two. We did have some concerns about the learning reviews, that we were not learning from some of these FTSE incidences. But since then, I understand things have moved forward significantly and that staff in ops are taking on board these learning reviews. So the right people are undertaking the right reviews. So I think there is good progress being made on that since that committee. And lastly, the EOC 111, we did ask Emma to come back to us at a subsequent meeting. She's already talked about in terms of the challenges, in terms of the numbers and the clinical staff versus some of the call handling staff. But we also have some issues there around the culture in EOC and 111. And there has been a deep dive exercise and there are plans to take that forward. But we've asked her to come back to WWC and give us some more detail on the outcome of that deep dive exercise. I think that's it for WWC.
Thank you, indeed. Colleagues, questions on matters of workforce? Ali, do you want to come back and comment?
Yeah, it was just a brief comment to add on in the WWC. We had a full discussion around appraisal and the current rate. So we have taken some remedial actions on those as well. So I'll update WWC on those more next month. But the other one I just wanted to pick up, I think, at the last meeting, it was a live issue, I think, and it's the first issue on the paper, which is around. At that time, there was a national ballot going off for potential industrial action. Obviously, that's concluded now, and I think people will be generally aware that there weren't sufficient votes to take either strike action or action short of a strike action as well. A lot of it was action in that sentence. But as an issue, I think it's sort of closed now for a number of months because according to the latest area, you cannot sort of ballot again for some months. So I think that issue has abated for now. But
we must be sensitive to how our staff are feeling around these matters, and given other pressures going on in wider society, inflation pressures and others, these issues will be there, won't they, and will have to be managed. Right, colleagues, any questions or comments about what you heard about workforce matters? Are you content that both the executive and the board committee have got all the key issues under control? David?
Thank you, Chair. Just one point, because Sue, you've said it's a conundrum, and training and development always comes up. And I just want to clarify, because we've been having a lot of focus on clinical education today, but just that the committee is not only focusing on the clinical aspects, we're looking at development and training needs across the organisation at all levels, because there's a big part of our workforce are not clinical, and those professionals also have development needs, and we feel as an organisation if we miss the point. So I think it's just more of a point that I think also came out the committee, is just for anybody who's watching, this is not only about clinical development, it's about organisational development.
And finally, for me, just a plug for the Agile. I'm glad you've got revising the Agile working policy, or developing one. Just that is a group member of staff that it's very easy. They're working from home. There's a large group of them, and I think we've got to work extra hard to make sure they feel really integrated and part of the enterprise. They're not used to working in decentralised locations like our crews. They're used to working in a larger setting, so we need to be conscious of that, I think. So can I move on to the next item if people are content that workforce matters have had the appropriate scrutiny and discussion? Thank you indeed. So we move on now to the finance and investment issues. Phil Astle.
Thank you, Chair. Just to give some headlines on the financial position and the outlook. The positive news is that we're on track for the current year against our plan. I think the risk of non-delivery of our financial targets this year is very low. The position is obviously, as you'll be aware, supported by a raft of non-recurrent funding issues, and there's significant sort of uncertainty moving into next year in terms of what our recurrent funding is likely to be. Just to give sort of two examples of that, one is part of the risk that's gone away for the current year is that we've received 6.8 million funding for NHS 111 first, but we have no certainty as to what level of funding we will receive for that next year, nor do we know whether we'll be funded for full demand, which is over and above any funding we've had this year. So that's a risk. And then the COVID funding, which we've had this year, some around 15 million, we now know that's going to be reduced, or we believe that's going to be reduced by around 57%. So while the COVID funding this year has been wholly adequate for our purposes, I'm not sure we could say the same thing next year. That there's a degree of uncertainty in terms of what the related costs are likely to be, and there's a number of other sort of underlying pressures. The other sort of caveat is that although we're on track to meet our targets do include a deficit for the year. We're not used to making deficits in the past. We've got a pretty good track record of achieving at least financial balance. So we're into sort of new territory, and clearly we need to think of our strategy to get back into surplus in future years. So part of that is we have the planning guidance out that came out on Christmas Eve. So we know we're moving back into sort of negotiated contracts next year. The exact form of which we're not quite sure yet, but it's likely to be similar to what we've had in the past, sort of cost and volume caps and collars and marginal rates and so on. So that's a sort of challenge for us. I think the guidance that we've received is quite helpful in terms of the requirement on us to meet C1 and C2 targets, that implies that there's a requirement on commissioners to ensure that the resources for that are fully funded. So I think there's sort of two key sort of issues in terms of our approach to next year, some of which we've touched on already. I think we need an informed and resolute approach to our negotiations with commissioners, and to ensure that we have sufficient funding to meet performance and financial targets. And secondly, I think we need a stronger emphasis and a change of approach in to efficiency improvement, both to make best use of available resources and to deliver cash releasing savings as required. Just circling back on the comments earlier, report from David, I think the 12% that David mentioned, which I guess is an indicative number at this stage, I believe it doesn't include any cash releasing element. So the 12% sounds like a big number, but in reality, the efficiency ask is going to be a lot more. And then sort of coming back to sort of Michael's question in terms of how that relates to financial strategy, I think we have to be realistic about how much of that we're going to be able to achieve in 1 year. But I know for sure that we need to change our approach and a much more sort of collaborative approach, in particular with sort of operational colleagues, and a change of in the way that we do things. So move away from cost improvement programs and move towards sort of efficiency programs which deliver everything for the organisation in terms of targets.
Thank you indeed, Philip. I feel very clear. Howard, do you want to bring out the highlights from the Finance and Investment Committee? Then we'll take questions.
Yes, just a few things just to go over. So the financial performance, we were assured based on what Phil has said around the outcome for this year. A few swings and roundabouts, but we'll be there or thereabouts. So that was good. The financial planning, as Phil has very eloquently said, this is a big issue for us. I think we do need, as he suggests, a slightly changed approach as to how we address it. But fundamentally, we're sitting on a deficit at the moment, and which was a quirk of the current block contract arrangement in the current year, and we cannot afford to have that roll over into next year. And that whole thing has got to be addressed, as well as, for example, the 111 first funding that you referred to in 2021. I mean, it's just sort of a bit crazy how they will agree to fund that in 1 year, and then it's open as to whether you fund it in the next year or not. It's just that's not really the way it should work. Anyway, so from a financial planning point of view, and it's sort of reflective in the performance comments I made before, it's sort of partially assured simply because of this. Well, two things. One is the deficit situation, which is, as I say, it's a serious issue that needs to be resolved. And secondly, it is quite difficult for us in the current circumstance that has been referred to, where we're trying to, if you like, budget and plan on a set of efficiencies which are an immediate requirement to get a plan in place for next year, when we know that we're right in the middle or at the start of a Better by Design program that will deliver, hopefully, a lot of these efficiencies that we're looking for, and yet we're not really in place just yet as to how we will deliver that. We've got some ideas and a plan, if you like, the Better by Design, but it's not there in terms of crystallized numbers that we can put forward yet. So we're in this quite difficult situation as to how we put together a budget for next year. But what we can do, and I think Michael mentioned this earlier on, is make sure that the stakeholders are well informed about, the thoroughness of our transformation program. And so, although we're sort of saying, well, you know, these efficiencies are not clear just yet. They will become so, and just make them well aware of what we're doing, because I think it is a very, very positive thing that we can sell to them. So that's the financial planning side. On the fleet, we had a good paper on the fleet. So the issue regarding Fiat seatbelts was raised, and we've now got at least a way forward on that thorny subject. So well done for getting that in place, and we just hope that can deliver in terms of those ongoing risk assessments for individuals. A couple of good things were the setup of a fleet user group to help ensure those and other issues with regard to the vehicles are resolved, and also a driver safety forum. So we obviously heard earlier on about the RTC at the beginning. There has been slightly concerning trend of these severe accidents, although there are no themes emerging, and our sort of claims record is not out of line with the rest of the ambulance service. But if you look at the data, it's just slightly concerning in the last sort of 6 months that we've had perhaps more than we would normally have in terms of those serious accidents. Anyway, a driver safety forum has been set up to look at that. And then we had just an internal audit review on the fleet side, which was a little bit disappointing, but in terms of having established a new system for monitoring our fleet and fleet statistics, those data weren't being used. But I know, obviously, we've heard that is now sort of out of date almost before it's published, in the sense that David is picking that up, and so we now start publishing those statistics. And once those statistics come out and the questions come through, that will reinforce the whole process of monitoring the fleet efficiency as well as the fleet effectiveness. Finally, we had a very good paper on strategic estates, and we were assured on that. And we had the green strategy, so we were assured on that as well, which we've covered. Thank you.
Thank you, Howard. I think Emma's got a thing to ask. Emma?
So thank you. It was just to add one thing, Chair. I think we mustn't underestimate the challenge it's going to be in terms of having the conversations with commissioners this year. Phil very well described the document that came out just before Christmas. I will add one additional thing that directly concerns me. So historically, hospital handover time has been set at 15 minutes. This has been the ceiling for it, and anything above that has been deemed to be unacceptable. We know that everybody is challenged around that. Particularly 60 minutes has been as deemed to be a situation that should just not happen. The new guidance changes that. The new guidance says that 65% of handovers need to be in 15 minutes, with the other remaining 35 before an hour. So one could be cynical and say that takes you to 59.59 for 35%. This is a significant potential, may not be realised, impact on hospital handover time in light of the conversation we had earlier about job cycle time and efficiencies. So I think it's a really challenging position, because Phil's absolutely right. We have to get better efficiencies at the time that we're trying to find a way to develop the new model, and some of the guidance actually contradicts some of the ability to implement some of those efficiencies. So I do think there has to be, and this is just to note the challenge around having some of these conversations going forwards.
Thank you for raising that, Emma. I think the colleagues who read the Health Service Journal will know yesterday the Secretary of State quoted about 4-hour targets being in A&E being inappropriate. And whilst what we've got to ensure here, whilst targets are revised in one part of the health service, they don't knock on to other parts. And the poor person in the middle is the patient, and using in the back of one of our vehicles. So we do need to keep that. That's one I would ask the executives particularly to keep a close eye on, to make sure there's no perverse incentives there, or there's no disincentives built in by the health service not taking a joined up view. So as well as others that are on a high pay grade to us, they will take that in mind, but we must keep that in place. We really must keep an eye on that. So other questions? So I think David and then Tom.
Just a comment on that assumption is costing us about 70 whole-time equivalents for next year's plan.
Yeah, 70
whole-time equivalents is the delta that Emma has just described. and that is what we need to be prepared as we go into commission discussions around how some of the assumptions play into what our workforce plans are.
So that's by flexing hospital waiting times, A&E handover times, that could cost us the equivalent of 70 whole-time equivalents.
Yep.
Yes.
Well, there's the benefit of a more proactive workforce modelling you're introducing, David. Well done. At the same time, it means we've got to get our act together, making sure we put that case. That's a real quality issue there, which concerns me, as well as the issue affecting our staff. Sorry, Emma, I cut across you. Okay. Tom?
I was just completely agreeing with you, Chair.
That's on the assumption that if you like, the worst case, they meet their targets, but it's the worst case in terms of the handover times. Yeah.
Yes.
That is the assumption that they have made in terms of the profile of delays in the operational planning guidance they issued on Christmas Eve.
Thank you. Final word, Tom.
Yeah, sorry, so I just want to come back to the planning guidance. So obviously the focus on category 1 and 2 is really important because that's potentially life-threatening, and these are very, very sick patients. What does it say about category 3 patients who are often very vulnerable and aren't well served, consistently? And in the absence of national targets on this, as a board, do we need at some point to come back and think about, on patient safety and quality grounds, setting some sort of target ourselves so that we can keep a focus on those patients too?
Yeah, I think that's a good suggestion, Tom. I think it remains sorry in the round with this, which very full discussion. I think clearly as we prepare for the next contract round, and in some parts of the health, in some parts of the public sector, the word is COVID is over. Remove your masks, all life can go on. Those of us work in the health service see a completely different world. Either way, we've got to be clear what world we're in and how we're going to go forward. So I think getting our negotiating position appropriate and making sure that's properly informed. So I would ask the Finance Committee and Performance Committee, Howard, under your joint chair, to be really working closely on this to make sure that the executives do have clear board parameters to work within as part of that, and when are the trigger points to come back for full board discussion regarding our approach to the contracting round, because it's clearly going to be a challenge this year, and we're all part of the joined up NHS, of course we are, but we also carry statutory responsibilities we can't get out of. So we've got to make sure we know our position there. I think the final point, especially really for you, Philip, is we've really got to be able to articulate our case here clearly. I'd like the board to be briefed with some clear bullet points regarding where we are regarding our negotiating position, the key headlines, the key risks we're running currently around funding and what that could lead to. I mean, that one soundbite alone that David introduced regarding flexibility around hospital handover times alone is a powerful statistic, but some clear briefing. So when we're meeting people in the wider ICS, all of them are new on the scene. Many of them are new now. They've got new people entering the arena who won't have the corporate memory that we've got, and I think we do need some extra work on this to make sure that we've got our case collaborated. But I think on that I'll close discussion down on the performance report. Very detailed overall report, but I think it's well worth spending the time on. Audit committee, Michael.
Yeah,
you wish to summarise?
We met in December. Just to go through, I think there's about 4 very quick headline points. So as a board, we have a statutory responsibility to be transparent and report our performance, both in terms of quality, patient care, and also financial stewardship. So I'm pleased to report that we can give assurance that the Trust has a robust plan for producing its next set of financial statements and annual report, and we approved the audit plan by the external auditors, KPMG. Again, for the record, KPMG, following competition, have been appointed by the council for, I think, another 2 or 3 year period, and I think that's a good result. My observation is it's a high quality audit. In terms of internal audit, in response to some concerns in the organisation that predates Christmas around how Better by Design was being developed, we asked internal audit to undertake a review, initial review of the governance around that programme. We touched on that today. One of the issues that have come up, but I think it's worthwhile making this comment in the public domain, was some concern that we had a chief operating officer and a lot of power was invested in that person and that we hadn't got a chief finance officer because David Hammond performs the role of chief operating officer and chief finance officer. We asked internal audit to look at the NHS more widely and the public sector more widely to question whether this was unusual. I know from my own professional experience, in the private sector, you would probably have two separate roles. In the public sector, because of limited resources, it isn't uncommon to have the combined chief operating officer and chief finance officer. I think it's important that people recognise the cost of having a chief finance officer and a chief operating officer. It's taking resources away from the front line. So the advice from internal audit was that this is fine as long as we have appropriate separation of duties wherever possible, and where David Hammond as chief operating officer is presenting to the board and as part of the governance certain plans, there is sufficient financial challenge. I think the fact that we have Philip Astle here today presenting financial information and other aspects of the controls that we have in place, internal audit concluded that having that role in David, both finance and chief operating officer, was satisfactory. What we did say, however, as a committee, we would continue to monitor that arrangement as the year went forward, and that is what we will continue to do. There are some other aspects around the governance about better by design which could be strengthened. I said this meeting of the committee was back in December. Action is being taken, and I've had separate meetings, as I know the chair has, with Philip and Peter as company secretary, to look at the governance around better by design, particularly focusing on the integration issue, that we can have assurance that there is appropriate integration going forward. And I think that will be announced or will be formalised when we launch Better by Design next month. Two other aspects I'd focus on was we took assurance, as we always do, around the arrangements that the the Foundation Trust has in place to prevent and deter fraud in the way we use public money. And I'm pleased to report that the evidence from our internal audit and the NHS Fraud Service is that CCAM has a fairly good record to, well, more than fairly, a good record to report in that. And I give that assurance to the board. And then finally, internal audit looked at the arrangements that the trust has in place to respond to any major emergency that might arise at any point in time. Now, last year we got substantial assurance around this. This year we got partial assurance. I know this is something that Emma is looking at very carefully, and I think it is a reflection very much of COVID, of where we've been over the last 12 months. We need to focus on this, and I know Emma is doing so, and we will come back to this at the next audit committee meeting, which will take place at the beginning of March. So overall, Chair, I'm pleased to say that the work of the audit committee, while we had some issues, we can give overall assurance that the governance arrangements within the trust are fit for purpose.
Thank you very much indeed. Colleagues consent to accept that report? Thank you, Michael. We move on. We've got linked to the audit committee, but we've got three important reports that we need to receive at the board and comment on if appropriate. So the first one is the Learning from Deaths report for quarter 4, 2021-22. 2020-21, I'm assuming. Should that be?
2020-2021, Chairman. Yeah. Quarter 4. Yes, thank you. So this report has already been presented to QPS, so I'll present the highlights. Looking at the deaths in quarter 4, we had a significant peak in January of 949. The previous highest that we've reported in any month was 818 in April 2020. So that is a significant increase, and the numbers were up in every age group above 40. I think that is probably a reflection of COVID at that time. As you know, we do 60 structured judgmental reviews every month, every quarter, and the results of that are that the care provided was good or excellent for the vast majority of patients. We look at the avoidability of deaths in those patients, and decide the view of the reviewers was that there was one death that was possibly avoidable. That means that there was a greater than 50% chance the patient might have survived had they been managed differently. That case was referred on to the serious incident group for review. This was a gentleman who rang in with chest pain, was given the priority of a C2, but we had a delayed response. The call was upgraded to a C1 when he went into cardiac arrest. We will get the report back from the serious incident group. That was part of a themed serious incident investigation. There was evidence of slight avoidability, so almost certainly not avoidable in 5, and of the other 54 patients, death was felt to be not avoidable. During this quarter, we undertook a review of the child deaths, which is not something that we routinely do, but I had asked Richard Quirk, who undertakes the paperwork for this, to undertake a look in depth at the child deaths. We had 14 child deaths during that period. 5 of those cases were end-of-life care, and 2, sadly, were teenagers, one of whom died following being hit by a train and one as a result of hanging. The care provided to those children was either excellent or good in 9 out of the 14. The care was either poor or adequate in the other cases because of delays to response to what were all C1s, but in no case was this felt to have influenced the outcome of the case. The care on scene was judged to be excellent in all those cases, and there were, of course, a high rate of transfer because of the procedures that are used for any child death. Just to highlight some of the actions and recommendations coming from the report. Firstly, we noted the excellent practice that was undertaken by our crews, the compassionate and caring that they gave to the relatives and individuals on scene, the support that specialist paramedics provided to our crews, both paramedic practitioners, CCPs and our colleagues on AAKSS. We noted the delay to C1s that had been highlighted in some of the cases, but fortunately the impact for all of those cases was regarded as minimal, and the one case where there was an impact was referred to the serious incident group. One of the aspects that we wanted further work on was the decision to commence resuscitation. We flagged 2 cases where there was a delay in resuscitation or it wasn't commenced at all, despite there being evidence that the patient was likely to have been alive at the time the call was made. So that's been referred to the professional practice group for some more work. We're quite clear when resuscitation can be terminated, but it's actually less clear when you should start resuscitation. And the general rule of thumb is that you start resuscitation while you gather evidence to decide whether there is either a DNA or CPR order in place or resuscitation is likely to be futile because of the circumstances. We noted that there's no way currently of flagging those patients who have either a mental health or learning disability. And because that's not flagged, it's unlikely that the random selection of 60 cases for review will pick out those patients. So that's currently a bit of a weakness in our procedure. We also, as we highlighted earlier, don't look at those patients who we do get to hospital alive, but that who subsequently die. And we may influence the care of that group of patients. And that's something that I think we need to develop going forward. We came across a number of patients who were clearly at the end of their lives and actively dying, and yet they had no end-of-life care package in place, nor did they have a respect or DNAR CPR order, and that was of concern. We also highlighted 2 cases where there were concerns flagged about the primary care provided to the patient. That was just 2 cases, and I think we just wanted to see whether that was an emerging trend. And finally, the support that was provided for the staff in some of what were sometimes quite sad and distressing incidents was really very good. So concludes my report, Chairman. Happy to take any questions.
Thank you, Fiona. Clearly a lot of attention is given to that very important subject. Any questions or comments? Tom, was there anything you wanted to add at all? from the QPS?
Nothing really, David. Thank you, Fiona. These are really important and informative reports. I suppose when we hear how primary care end of life group respond to the approach that Richard Quirk is going to take to them, I think in April, it'll be useful to get some feedback on that, so that we just, we can continue to keep an eye on this, because I think having those plans in place when resuscitation is not right for that particular individual is so important.
And the point you make about joining up care, Fiona, around the developmental pathways regarding stroke and cardiac and so on, I think as we move forward in our contract assessment, contract negotiations and others, these are the points we do need to bring out, because of as we move towards more integrated commissioning, we need to make sure the patients get a good deal, don't they, in terms of our response, but also we get them to hospital. The hospital can deal with them. That's important. Michael?
Yeah, Mike said I'm not a clinician, but in my previous life, I remember doing a report to Parliament on end-of-life care, and I just asked the question of the two examples that you gave there, and you're looking at what our policy should be. But what happened in relation to the families of those people? Because it must have been quite stressful, or for their loved ones to be dying and not. There is no resuscitation. I mean, is that explained to them on the day why that happened, or was it just? I'm just interested that from a patient perspective, that was handled as best as it could be.
So I think the concern is that resuscitation wasn't started, and there was no really good documentation as to why it wasn't started. It doesn't mean it wasn't the appropriate thing to do. But at the time they made that decision, they haven't got all the information that they could have gained from the family.
Okay.
The concern that we had is that we come across an awful lot of patients who don't have an end-of-life care plan, and yet the families realise that they are dying and often express to us the desire not for us to continue resuscitation. So that's generally joint decision making, and that's fine. But we are flagging to the regional end-of-life care team that this is an area of focus.
Okay, thank you, that's very helpful.
Judith, I saw you join the screen. Anything you want to add to that point at all?
No, I don't know why I suddenly joined. It must just be moving around.
Okay, thank you. Let's move on to the next question. Chris, then Howard.
Thank you, Chair, and thank you very much, Fiona, for such comprehensive report. I just wanted to ask you, I think in terms of when the patients are handed over to hospitals, and I know is there a way that we can try and find out the outcomes of those patients, not only because that would be very helpful, particularly for staff who have actually been caring for those particular patients, to just see the outcome of these individuals?
Absolutely, Chris. It would be probably the one thing that all our staff would really appreciate. But this is just not possible at the moment. We cannot get that data. We did at one stage, and in fact through the efforts of the individual who is now our head of clinical audit, managed to establish a feedback mechanism with some emergency departments. It took ages, and we didn't get the full diagnosis. All we got was whether the patient had been admitted or discharged, and if they were admitted, where they were admitted to. Or whether they died. So we would know, for example, whether they were admitted to ITU or to the ward or to theatre, and that is of some benefit. But if you go through A&E records, you'll often find that there isn't a particularly definitive diagnosis there. So even getting the A&E records back would probably not help the staff that much. But this is all around trying to tie up the information governance between us and the hospitals.
But we have got integrated care systems coming into place where some of these things with a level of executive influence and integrated care system level. So this is where we need to start. Perhaps we get some movement into what's a very important issue to assure quality. So let's put that on the agenda for those discussions. Thanks, Chris. Howard.
Yes, just a question on timing. Aside from the misunderstanding in terms of the dates at the beginning, this is a report that produces results from 2021, so that's up to March 21, which seems like quite a long time ago, given that we're in sort of Q4 of the following year now. I was really just sort of seeking some sort of assurance around the learning, obviously this is the report, and I understand there's a process that's gone through and a final report is produced. Can I get some assurance that the learnings that come out straight away from any sort of serious incidents, from deaths, are made sort of more quickly, and that this report then comes as a follow-on?
So I think that any case reported to the SI group, if there are immediate actions, that comes through. We go through the death sometime afterwards. So, for example, we're just completing Q2 of the current financial year. So Q1 has been done. That report is being progressed through, and we're just doing the reports on Q2 at the moment.
Okay, thank you.
Thank you. So, board. Are you prepared to take assurance from the learning from deaths report? I think it's a comprehensive report. I think with a clear, detailed process in place with significant learning, which is part of the feedback loop to all concerned. So thank you for your comments. Thank you for you and your team, Fiona, for a comprehensive report. The final two items are patient experience and incidents. Annual SI annual report are to note. But Judith, do you wish to? Anything you wish to say about these two important reports?
Yeah, I think in terms of the we're formally required to present you with a complaints annual report, but we don't believe that gives the total picture on patient experience. So what we have presented is a patient experience report that talks about some key work through the year, starting to embed the patient experience strategy, which was approved in May of that year. And then it talks about our complaints and compliments. We get far more compliments than we do complaints, often in the same letter. People will complain that we were delayed getting to them, but then say, but your crew were lovely, and that's fed back to the crew. We still have similar trends, delays, which kind of matches the trends you see in serious incidents, and crew attitude, conduct, which tends to mirror other areas of the NHS, and a lot of learning around NHS pathways, which is the triage system that gets fed back nationally. I think it also highlights the relationships we've been building up externally in relation to patient experience. We regrouped the patient experience group post approval of this strategy, and we've had a group that are learning to work together more cohesively and more representative, and certainly more representative externally to CCAM as well as internally. And we've also developed relationships with Healthwatch. I don't know if there's any questions for that, David.
Thank you. It's an important report. Colleagues, you content with the I think the themes of the complaints have been picked up in the various subcommittee businesses. Our focus on performance as well as clinical outcome. Tom?
No, it was only briefly just to follow on from Judith, because we obviously went into detail in this report at the QPS, but we are having a detailed report, a paper on patient experience at the next QPS, because we recognise we need to keep a close eye on patient experience.
Well said. Okay, thank you. Should we move on to incidents and serious incidents annual reports?
Yeah, a lot I've already covered when I talked about patient safety, so I'll skip those areas because it does demonstrate our approach to starting to embed the safety strategy. I think the positive is year on year we demonstrate an increased reporting in incidents, or we did till that year, and that doesn't mean to say we're becoming more unsafe. That represents a really positive culture that people are prepared to report incidents. And year on year, what we have demonstrated against that is a reduction in moderate or higher levels of harm relating to those incidents. So most of those incidents that were reported were low or no harm. Some of the trends were affected last year by mechanisms we had to use because of the pandemic, such as we initially had to use Datix for track and trace till we had other mechanisms. It also talks about harm reviews, which we continue to do, and we did some last year in the Kent area around a and other areas, but predominantly the Kent area, around about December, January time, and November, because we were worried about the increasing handover delays there. It emerged over time that was actually due to the emergence of the Kent variant, but we didn't know what we were seeing at the time. What we found was actually, it was interesting because we found very low harms or no harms out of our review, which contrasts to the ACE review of handover delays that was done at the same time, that's been published recently, that found potential levels of harm to be quite high. But we actually worked with providers, and I know you were asking previously around can we get feedback from hospitals. It was a small number of cases and it took a lot of effort to get feedback and try and work with hospitals, but it really did help demonstrate that the levels of harm more in reality. And what we found was that actually a lot of patients, the prevention of harm while they were waiting outside the hospitals was due to the care given by our crews. We actually saw early warning news scores actually improving as patients were waiting for care in hospital. In terms of serious incidents, we are a higher reporter, but that's because we operate an open culture and work well with our commissioners. If we believe it's a serious incident, we report, and then if later subsequent investigation identifies that it didn't fully meet the SI criteria, they're very happy to downgrade. I think that's kind of the same, that the SI is the highest category of SI reporting, serious incident reporting, was again delayed attendance. We are also showing from our serious incidents improvements in the work that CCOM has done over the last 3 years. And in particular, when I first joined the trust, we saw lots and lots and lots of patients who came to harm, waiting a long time for an ambulance who'd fallen. And we don't see that nearly as much now, and we're pretty sure that is because of some improvements in performance, but a lot of it is due to the work done in our EOC with clinicians to keep patients safe and monitor them while they're waiting.
That last point is particularly encouraging, Judy. Thank you for sharing that. That's important. My colleagues, questions, comments? You happy to accept the report of incidents and SIs? It's getting the attention we deserve, and I think it was a collective board view, Judith, which you've articulated, but it's worth stating again. We do encourage people to speak up to make sure that we are open about where we could have done better. But equally, we're being open around make sure our staff are aware of the fantastic feedback they're getting from the public, and I think it's very encouraging, to say the least. Makes one very proud to be associated with the organisation. Well done. So just to move on to some very final item on business cases, we have 4 business cases here, which have all been through the detailed scrutiny by the Finance Committee. So I'm not sure which executive wish to. I mean, you're going to just anything you particularly want to say? I mean, hopefully people have read them. They've been to the Finance Committee. Is there anything particularly you just want to emphasise to the board of the importance of these cases?
Chair, what I think we do is Emma will take the first 3 all together, and then we'll hand to Phil to do the other one. But they're all they should be fairly self-explanatory.
Over to you, Emma.
Extremely short, Chair, just to say the first 2 obviously COVID related. They're follow-ups to the original business cases that came out earlier on last year, because this has been an evolving picture. So this is very important for us to capture all our costs for the under COVID, so we can reclaim them as per the scheme that Phil talked about in the finance piece earlier on. The third one is about the 111 first. This is the additional monies that were negotiated and from rebaselining it earlier on. Must be about a year ago now, spring last year. The monies have all been finally agreed, and this is the business case associated with it. So that's the story of where they're from and what they're about, Chair. I don't think there's anything much more to add at this point.
This is codifying what's happened and making sure there's good financial practice around our investments. So well done to all for making sure that's the case. So, thank you. I'm moving on to the licensing of computer software.
Thanks, Chair. Yeah, I won't get into the technical detail of this because I'll soon find myself out of my depth. But essentially, there's a requirement from NHS Digital that we demonstrate that our email system, which is on a local tenant, is accredited as secure, and we have to remove NHS net accounts by the end of January. So a review was undertaken that identified the need for specific security features, and they related particularly to the use of email by CFRs and operational staff. And the bottom line is that this requires the turning on of two additional licenses, which sounds simple enough, but the cost is not insubstantial. It's 232,000 in a full year. So over 5 years, it's above it's in the realm of board approval level. But it's something I think I hope you'll agree is something we have to do. We don't really have much choice in the matter.
I think that was the view of the Finance Committee, which Howard chaired. And just one detail there, Phil, you mentioned about the CFRs. So that means our CFRs will now have CCAM email addresses, which again is an important point to our valuable volunteer workforce. So they make an amazing contribution, and that's an important step forward in terms of making everyone feel part of the broader family. So I'm glad that's a byproduct of this investment as well. So, board, are you happy to approve those 4 business cases? Okay, thank you. Are there any other items of urgent business? Concluded. Review of meeting effectiveness. Well, please fill an anonymous survey in if you wish to give me any informal feedback. I hope you feel the meeting was effective. Everyone's had their say, and we've got a fair balance between governance, scrutiny, and making sure our patients are safe. So all happy with that. So I'll take silence as assent. Sorry it's dragged on, but I think there's some really important business there we have to transact. So it's now approaching 3:30. We'll now give the opportunity for those who've been patient enough to sit and watch and listen to our deliberations. If there's anything that members of the public or our staff who have been listening, if there's anything that they, in terms of questions they wish to ask about the board business, please speak up. I should look for your hand to be raised. My other colleagues will do that as well. We must have warned people. We must have worn them down.
Yeah, can't see any hands, Chairman.
Yeah.
There's one. Sorry, there is one.
Linda. That's good. Yeah.
Hello. Sorry.
I apologise. That's why we're here to listen. Hi, Linda.
Nice to Hello, and thank you for a very informative meeting today. I have a question which is steered towards David. I think it was you delivered the green strategy.
Yep.
David, can I just ask, because it's a very interesting strategy actually, in terms of the transition over to electric vehicles and installation points, is the organisation linked in or with other organisations, or are they undertaking this task in isolation? And I ask that because obviously there's grant availability at the moment around supporting the procurement of EV installation points and electric vehicles, but also there's a bigger piece of work that's been going on, particularly across Kent and Medway and I think other councils, in fitting electrical charge points within community areas. But also I'm just wondering about the charge aspect, because if it's something that the future vehicles for CCAM actually visiting, say within the Kent and Medway area in particular, are they able to just pop onto a charge and charge those vehicles if necessary?
Good question, actually. Thank you. Are you in a position to answer, or do you need time to?
I can answer aspects of it, Linda. So we are seeking to engage with the right people that will help us understand the overall plan, and I think that is where we need to understand what the community engagement opportunity is. If you're referring to how we utilize public charging points as part of our operation, that could potentially be difficult as a result of how we operate our vehicles. We wouldn't I don't think our model is going to rely on our ambulances stopping at forecourt chargers. But at the same time, we don't know what the forecourt charging infrastructure of the future will look like and how effective that will be. So part of the thinking needs to mature in parallel to what is happening in the electric transport infrastructure development as part of the UK transport strategy in the round. And that's where some external advice that we're seeking is going to be helpful. In terms of the vehicles themselves, they are standard. So it is the type 2 or direct charge type. We're not making anything up. These are anything we do needs to be in line with the industry standards when it comes to electrification of vehicles. There is an interesting point about potentially how we utilize places where our vehicles are idle to charge the vehicles. And we've talked about hospitals handovers today. So that is a place where we have natural pauses in where the vehicles stop, and how do we utilize potentially, the drop-off points of the future in hospitals where we know that our vehicles are there to be able to top up. And what we know about electrical vehicles is you never go from 0 to 100. You always oscillate somewhere in the middle. But there's a lot of work to be done to understand what that model of the future looks like. In terms of the grants that you've mentioned at the beginning, I am not aware of any grants that are available other than the ones that we have mentioned today around the trial that we are running with our SRVs, and we are installing some additional charge points. So it'd be very interesting to get some of that information, and you have my contact details in the strategy paper, and I'll be very keen to pick up with you separately outside of the board. One of the things we are trialing as part of our trial is the standard 7 kilowatt chargers that most houses will install won't be enough for us. So we are looking at the range of 22 kilowatts up to 80 kilowatts, which is quite a high power charger. So we can test how that works for our make-ready centres, which is where initially we think we will be returning the vehicles to and then sending them out for operations again.
Mm-hmm. Yep, no, that's absolutely fine. I can get in touch with you on that, because I'm just aware that there's a bigger piece of work that's ongoing at the moment with some of our NHS trusts in Kent and Medway, certainly around installing those electrical points. So I think that would be very helpful for the fleet.
Brilliant. Looking forward to that. Thank you.
Okay.
Good example of integration in action there as well. If we can all on the same charging points, that'd be even better. So any other final comments from the board? Or the public, rather? So we can now formally close then the public board meeting. The board will reconvene in private session at 3:45 with a few items to transact. Thank you.
Thank you.